So I'm going to do the land acknowledgement, and my colleague Susan will do the prayer. The Ontario Science Centre sits on the ancestral lands and territories of the Haudenosaunee Confederacy and Wendat peoples and the Anishinaabe Nation, which includes the Mississaugas of the Credit First Nations and the Chippewa. We acknowledge this land. This land is home to many diverse First Nations, Inuit, and Métis peoples. We are grateful to work with, learn from, and partner with Indigenous communities in peace, friendship, and respect. Susan, do you want to lead us in the prayer?
And we know that there's a God that created heaven and earth, the land where we stand. For those who believe in Allah, we respect you. And for those who believe in God, even those that don't, you're very important. For the Christians, let's humble ourselves for the word of prayer, as well as Muslims. Heavenly Father, we appreciate you for the gift of life. We know that we just didn't land on earth just like that. We know that you organized and prepared and created us to take this world ahead, to socialize, to take care of health, to take care of your creation and vegetation, to be able to exist and to run life. We appreciate that you've given us that opportunity to do that. And even this morning, we are going to share on how we are going to continue surviving and working together to progress in what you created and what you designed, and in how we can serve communities even better, because that is your heartbeat. In God's name, I have prayed, and let all God's people say, Amen. We welcome you in a very special way.
Great, thank you so much, Susan. At this moment, I believe our guest of honor is going to open up the career fair so that for those who are interested in the career fair can continue engaging with the folks around. And then he's going to come back in, give us the opening remarks. And then the conversations will start accordingly.
In a special way, our dear guest of honor and our special guests, thank you for honoring us with your presence. It's a busy day, it's a Friday, it's a working day, but you've honored us that time, and that's very important. Thank you very much. We respect you, and we know that you're going to have a great time here. Thank you. So at this point in time, our dear guest of honor, together with the delegates that you're with, you're going to lead us as we come after you, as you inspect the career fair. Thank you. DJ, if there's any music for us as we do that.
No, actually, there's a change of program.
A change of program?
Slightly.
Okay, tell us, Henry.
So what we are going to do is make the remarks first. So I'm going to invite George Willoughby, the executive director, and someone who has been very fundamental or key in organizing this event, to come and give opening remarks, give us the preamble of the conversation. After that, he's going to invite the guest of honor to give his remarks. And after his remarks, we shall go and officially open the career fair. Again, thank you so much for your patience.
Hello, hello, hello. A very good morning to you. If you hear my voice, just wave, just wave. Thank you very much. I am very delighted to be here this morning. And also, I'm very happy to see everyone smiling and very beautiful and handsome. My name is George Willoughby, and I'm the Executive Director of Global Events Canada, but also the convener of the International Conference on Healthcare and Social Work. My role here is to provide some welcome remarks, and with that regard, we are here as partners, collaborators, learners, and researchers, and everyone that is here. Allow me to just give you a run through my opening remarks. I will start with the introduction. My name is George Wilobo, the chairperson, organizing committee of the International Conference on Healthcare and Social Work. I'm also the executive director of Global Events Canada, the convener organization of the IHSCS, and HSCF, which is Healthcare and Social Work Career Fair 2024. I must say good morning to all of you, our virtual conference attendees. This is being streamed right now live on all social media platforms. We are so glad that you could join us today. Before we get started, we would like to thank you for clearing your schedules to attend our event today. On behalf of the organizing committee, we welcome you all to the first International Conference on Healthcare and Social Work 2024. I want to thank all our partners, collaborators and sponsors for ICHS 2024, especially Dixon Hall. And Dixon Hall is also our silver sponsor for the ICHS 2024. Thank you very much. We welcome all the international delegates that traveled from far, from different countries that have managed to join us today. We want to thank our chief guest, Honorable Adil Shamji, for honoring the invitation. Thank you very much. I want to thank the entire organizing committee for consistent planning and execution that you're seeing today here. We have an engaging lineup of topics and activities for the day. Without further ado, let's start by providing you the background of the conference itself. Now, as a trained and qualified healthcare professional that I am myself, I'm a biological scientist by profession. I go to Canada to continue with my practice. I was hit with the systemic reality check of having to go back to school in order to get into the sector, which got me demoralized. I ended up giving up after trying so hard to accredit my credentials with World Education Services. The affinity to get into the sector threw me into the community support services for people with development disability. 3 years down the career lane landed all healthcare and social workers face to face with COVID-19, where social workers were the central support system for the fatigued healthcare professionals. COVID-19 exposed so many weaknesses and strengths of the healthcare industry world over, with the most important acknowledgement of integrated care. Now, while brainstorming with Lydia Namugenyi, a mental health specialist, we realized the need to understand further the attributes and relationship between healthcare and social work. And this is how the theme health in a social perspective was born. The need to contextualize the concept took me to Dr. Sumi, that is just walking in right now, whose research paper on integrated health and social care informed the concept and the context of this conference that you're here in to attend today. Now, the background of healthcare and social work career fair. The challenge of most newcomers to Canada in joining the healthcare and social work sector is one of the reasons Healthcare and Social Work Career Fair 2024 was born. Currently happening outside the doors of this conference, we have collaborated with many employment service agencies, education institutions, community organizations, and recruiters to extend the opportunities closer to the people, especially immigrant population. Now, the purpose and objectives of the International Conference on Healthcare and Social Work. One, we want to understand the understanding of integrated health and social care, interdisciplinary insight, fostering collaborations between healthcare and social work professionals, enhancing the understanding of integrated care as a multidimensional construct of healthcare and social work. Policy development, generate discussions around policies and interventions that address the social determinants of health and promote well-being on a global scale. Workforce challenges, establish exposure of challenges faced by typical healthcare and social care providers from a Canadian perspective. The conference structure and expectations for today. The conference shall employ presentation, on selected topics, followed by panel discussions, as you can see the setup, and the audience engagement through questions, interactions, and opinions. The conference shall also be streamed live on all social media platforms. Pictures will be taken throughout the conference, and any reservations can be communicated through our contracted media persons, M&G Media, that is in the house today. Our team members or volunteers shall be available to provide information and any inquiries. In conclusion, therefore, I wish you all the best throughout the 2 days of the conference, and we hope God shall give us the grace to inform policy and change lives. Thank you once again, and thank you all for being here today. If you are watching us online, we appreciate you for joining us today. And I want to take this opportunity to recognize the presence of Kingsclear First Nations Child and Family Services. If you can just wave to us if you're here. Yes. We want to recognize the presence of Lindsay, this name is very difficult for me to pronounce, and Laura Simcoe, all of the First Nations communities. And with those few remarks, I thank you, and thank you very much for joining us today. Now, allow me in a special way appreciate our guest of honor again. And for some reason, I didn't know that when I contacted your office, I didn't know you were a medical doctor. It happened, I think, just like I didn't know that you were a medical doctor. It's until when I read your profile, and then I'm like, oh, now this is the perfect fit for our conference. So without further ado, I allow me to welcome our guest of honor to officially declare this conference open. Thank you very much.
Good morning, everyone. Good morning. How are we all doing today? Oh, come on. I was walking around. I know there's some Kenyans in the room, so we can do better than that. How are we all doing today? Now we're talking. George said that I'm the honored guest. That's not true. You are our honored guest, and it brings me so much joy and privilege to be able to welcome you today to this beautiful riding of Don Valley East. And even more than that, to welcome you to this beautiful building, the Ontario Science Centre, which in Don Valley East for decades has been a center of cultural, educational, and economic prosperity and significance for everyone here in the riding and throughout Ontario. And that's kind of why we're here. Cultural, education, and economic significance, because we're here today for the International Conference on Healthcare and Social Work. We're here about connecting people with jobs from many different communities to make our province a better place. Now, you heard George was saying he was surprised to learn that I'm a doctor, and many people have asked me, why, Adil, would you, an emergency doctor, step forward for political service? And, I've been working as an emergency doctor just down the road at Michael Garron Hospital. I've been there for about 11 years now. And, after seeing patients after patients after patients who are all sick for various reasons, one of the things that was so frustrating for me is oftentimes someone would come in and they'd have an infection or a burn or some kind of wound. And I could prescribe the antibiotics. I could put on the bandage. I could treat the injury. But sometimes there were bigger reasons in the background for why they were sick in the first place. For me, what was the point of treating someone's frostbite if I didn't also help them not return to sleep on the street on a cold winter night? Now, why am I telling you that? I'm telling you because when you say that the theme here is health in a social perspective, you are 100% right, because nothing exists in isolation. That social perspective and background is critical if we want to achieve true health and true well-being for all of us. And that is why to be here today with you this morning, to start off your conference, is my privilege and honor, not yours. Now, our work today is doubly special because we are talking not just about health in a social perspective, but something else that is very important to me, and that is healthcare workers and extra specially social workers. Because at the end of the day, everybody cares about health, but we cannot have that health without the healthcare workers to enable us to achieve that. Now, typically when we talk about healthcare, if you ask the average person on the street, you'll hear the same two things will come to mind. Ask about healthcare, and people immediately think about hospitals and doctors. And I'm a doctor. But I know, probably because I'm a doctor, I know that healthcare means so much more than that. Because in order for our healthcare system to fire on all cylinders, we don't just need doctors. We need nurses. We need paramedics. We need respiratory therapists. We need personal support workers. And very especially, we need social workers. Now, this is something that has come up to me many, many times. People have wondered, what is a social worker? That's actually a tough profession to define. I find it easier when people ask me that question to say, well, it's hard to say exactly what a social worker does, but everybody notices when the social worker is not around. I think of the role of social workers, and of course, I'm not here just to talk about them, but I think, I believe a special mention is due to them. I think of the role of social workers as, imagine like in a car. We all know the basic parts. There's an engine, there are brakes, and all sorts of other things. All those individual parts play a vital role in the car. But the thing that keeps everything moving is the oil in that engine, the thing that keeps everything lubricated. What many people in the world consider to be liquid gold. When you start the car, yeah, the engine started, but there was something that enabled it to function, that brought everything together. And to me, that is the perfect metaphor for what social workers do. They help to lubricate all of the different parts of our healthcare system so that we can achieve that health with a social perspective. And so today we're here to celebrate the work that all of you do, whether you are a social worker or a paramedic or a nurse or a PSW. We're here to come up with better public policy so we can achieve success in all of the social determinants of health. And I know that we're going to be connecting people to job opportunities, and that could not be a more important thing than at the time that we are at in our healthcare system right now in Ontario. And so I join you in saying that the conditions of work are the conditions of care. We need to treat our healthcare workers right. It means fair wages. It means protection against workplace violence, supporting your mental health, combating against burnout. And only if we can do all of those things can we achieve the healthcare system that everyone in Ontario deserves. And so today I wish you every success and every opportunity to build new bonds and relationships, to strengthen connections, and collectively to work together and make this the strongest healthcare system that we can. Thank you very much for being here, and I wish you all the best success.
Thank you so much, Dr. Somji. Also honorable for those very wonderful words. We honor all our medical personnel whether you're a social worker or a doctor or a nurse, we are delighted to have you here and we honor you. Before you sit down, I'm gonna put another task on to you. I know you have been doing so many emergency tasks. Another emergency task that I'm putting in front of you is to open the career fair before you come back for the opening remarks. So please join us in opening up the career fair.
And before our guest of honor actually gets out, they all were dying and very, very enthusiastic to listen to you. So some of the exhibitors are in here. Kindly march out and be at your tables while the guest of honor comes. Thank you. Let's do that quite fast. Thank you very much. Okay.
Speaking well, ma'am. Hi. Yeah.
Wide. We're based out of Scarborough. We're actually
They're right. You said that you guys are sister
We're
organizations.
sister companies.
Yes.
Okay, wonderful. Okay,
So we have Tropicana.
Nice to
Hi.
Nice to meet you.
Thank you.
services.
Thank
Such
you.
a pleasure
Thank
to
you.
see you.
Good to see
Yeah,
you
thank
too.
you.
Thank you.
Organization.
So Tropicana Community Services, we are actually from Tropicana Employment Center. It's a division of Tropicana Community Services. We've been around for over 43 years. It's the first Black community, and we're serving people in the community. We have employment, we have healthcare,
And
actually
social
mental
service,
health,
mental
social
health.
services. Yeah, go ahead.
And daycare.
Daycare.
We are presenting only for the employment service
No,
today.
I'm looking at this.
Yeah.
Oh,
I'm seeing exactly where you guys are.
Yeah.
We're just not
This
too
is
far.
only for the employment
Center.
service,
Yes.
but our head office in the Hunting Road.
Yeah, Huntington and Matawan. We have a
Yeah.
job developer training. We have an ECE program connected with Centennial College.
So you must be very busy.
Very
course,
busy.
yeah.
It used to be specific for youth, but now everybody can join
Because
since we have the Employment Ontario program.
Now the employment Ontario program changed it to the WCC. You might know about it.
Yes.
So yeah.
I'm from the community. I got it for you. So okay. Thank you.
Even you said about I'm the medical doctor. Why I become a politician?
Yes.
Me and my son we were discussing about the same questions.
Oh, really?
Yeah.
Oh, my goodness.
Because my son studying the political science.
Yes.
We watch the agenda. We are most likely talk about liberals and
Oh, yes.
Yeah.
Sure. Reach out if I can help in any way.
Yeah, of
Yeah.
course.
Yeah,
And
thank
I
you.
love talking to you guys. So if I can, if you want any advice or anything, please ask me to reach out. Also, I put out a calendar every year. Your organization can help many people from their lives. I'm going to add you guys. Yeah, I see that because I know for the employment center.
505 Consumers Road.
Yeah. Hawasha, just grab this address.
Let me take a picture.
Should add that. Yeah, and then we'll add that to the calendar.
Absolutely. We have a lot of foreign trained individuals. We have a lot of people from Uganda and Kenya. And we involve refugees. We have job
So
development
important.
training.
Yes.
Include them. We don't
I'm very
mind
proud of
about
you.
their skills, like how they have to do their credential. We just, everybody is included. We
Only
register
one
them.
people
Yeah.
they don't have a status for the Canadian citizen, permanent
Right.
resident,
Right.
and the convention refugee. But the students, we will help you with our network program. Sorry,
Fantastic.
in the resource information. So we will
Fantastic.
help them with the resume rating, and they give them guidance how to find a job.
You're very
Those
lucky to
ones,
have you.
Yeah, we have summer program for students.
Yeah.
From I think June to the end of August, 15 to 18. Paid food subsidy program. We have a YJC program with Job Connections for for youth actually, age 18 to 29 as well. It's a paid training program as well. So yeah, we're quite busy. Yeah.
But we are looking for government to spend money.
We need more funding.
More funding from the
For
government.
our program, we need actually Tropicana need more funds
Funding,
to
yeah.
reach out to the community.
You have my
Yes,
Yeah, okay.
I'll send it to you.
You do
Please,
such amazing
please.
work. I
Yeah.
would like to help you.
Yeah, we help with housing as well and mental health.
We need a shelter for the community.
Write to me
Okay.
Give
so
this
that
to
we
our
can
director.
connect.
Okay.
Or do you have a card?
Oh yeah.
Ocean.
Hawasha? They need some help. And they're supporting our
Yeah.
writing. So
I'm gonna give probably our meetings and
And maybe. And
yeah, I
want
didn't
to
bring
give
mine because I'm supposed to come tomorrow, but I'm replacing somebody to. So okay, yeah. Yes, for sure.
she'll grab your she'll send you a note.
So here we have CDI College.
Hi there, I'm Carrie Harrison.
You? Hi, how are you?
How are you, Cynthia?
Wonderful, Ali. Great.
So this is our guest of honor. We are doing the booth, like the exhibition booth
Yeah.
run. And yes, you can talk about your college.
So we are CDI College. We are a healthcare and business technology college. We're located at 4 different campuses throughout Ontario. We have one in North York, Scarborough, Mississauga, and Brampton. And we are running programs from medical office administrator, addiction recovery and support for youth and families. We have IT programs such as network system administrator, cybersecurity. We have medical office programs. We have a dental assisting program. We have a wide range of programs for students. And we cater not only to those that have been born here in Canada, but we also have new immigrants that come in. We have a new immigration assistant program that we run as well. And many of our students are enjoying that program to help others come here to Canada where they can start a new life.
And what is the demand like for those programs?
Actually, the demand for healthcare is quite high at the moment. There is a demand out there, especially since COVID. You know, healthcare has taken a turn where we need it more so than ever. And now that everything has gone to online, we have a great demand for our cybersecurity programs and our network system programs. Because everything's going online, a lot of companies are making the move to be more integrated with technology. And so students are interested in getting into those programs where they can make a difference in their life as well as others' lives.
Wonderful. It's a pleasure to meet you.
It's nice to meet you as well.
Thank you.
Thank you.
Thank you so much.
All right, so there is a last recruiter here.
Yes.
That you didn't see. Yes.
Okay. Oh, I know you.
You know that?
And I do have to run you.
Yes. Oh yes. So yes. Yes.
It's such a pleasure to meet you. My name is Adel. I represent this riding at Queen's Park as a member of provincial parliament.
Oh, I see.
And I know about the amazing work that you do. I had the privilege of being invited to the Yihon Lunar New Year celebration. It was the most wonderful introduction to the amazing work that you do.
Nice to meet you too. Yeah, it's our pleasure to join this event. Yeah.
Wonderful. Good. I know you're very busy and working very hard, right?
Oh, I think everyone like that. Yeah.
It's such a pleasure. Wonderful to meet you.
Thank you.
Amazing
Nice
work.
to meet you. Someone try to sanitize this or something.
Okay, at this point in time, let's go back to the hall. To the hall.
No problem.
Let's go back to the hall so we can declare it open. Let's go a hall for a moment so that we can be declared open. Kindly, only a minute. Thank you.
Hi there. Go right ahead.
Hello.
My friends, I had mentioned before what an incredible honor and privilege it was to speak with you this morning and to join you. And I only feel that honor and privilege even greater after having had this wonderful opportunity to meet so many of the exhibitors and people that we will all have an opportunity to network and engage with today. And so in recognition of that, reflecting on the amazing people who are here, I'm so proud and happy to declare that the International Conference on Healthcare and Social Work, dedicated to health in a social perspective, is now open. And I wish you a very, very productive conference.
Thank you so much, Doctor. Right. All right. Who is excited to be here? All right, I'm equally excited. The next event is going to be Dr. Sui giving us the conference keynote address. And may I invite some folks who are still outside to continue coming in, joining us here today. Susan, if you want to take over. So it's going to take about a few minutes, about 2 to 5 minutes for folks to just come in, settle in, and then we shall hear from Dr. Soimi Chang telling us about her science, some of the original ideas that she has conceptualized, but also she has put on paper, pen to paper. I had the privilege to read some of her work. I must say I'm excited, but now I'm even more excited to hear from her and to see how she presents it to the rest of us. And I hope you are as excited as I am.
All right. Kindly use these 2-3 minutes to maybe wash your hands or grab coffee or tea or water. Okay. And then when you come back, we shall have our next addresser. You can use this time to just stretch just a little bit. In 2 minutes, we will be here back again. Thank you. Dear guest of honor, we appreciate you. A big hand clap as he goes away. That was very beautiful. Thank you so much. We appreciate you.
Somebody told me about it when I was still in He said to me, cry just for me. He said to me, education is a key. Yeah. As a little boy, I thought I knew what it was.
If you're still standing out there,
At this point, let's go back to the hall. Let's go back to the hall and proceed. Thank you very much, dear exhibitors. That was very, very good. Thank you so much for entertaining our guest of honor and for making sure that you blow the trumpet for the good job that you do. Thank you. We appreciate you.
Just like they for my freedom. He sang to me a song. They won't build no schools anymore. They won't build no hospitals. They won't build no schools anymore. They won't build no hospitals. All they build will be prison, prison. All they build will be prison, prison. All they build will be prison, prison. All they build will be. I am a prisoner. I'm a
My scar lift but the rain.
never see my
Zero, zero, zero,
never
zero.
go west of the Arizona border. You can turn the other way, boy, but you never get far. You'll be living a lie. If you want to see the wonders of the age, you must follow. Evening star, shine a little heaven on strangers, no dream where you are. You can see the loneliness of me. If I gotta fight, I can never be some follow the evening star. Never be somebody else's
as a result of these conditions and the needs of older adults. In fact, there is a statistic that's been going around that expenditures in the hospitals, 5% of older adults account for 55% of healthcare expenditures. So you can imagine the burden of healthcare needs that plays on the healthcare system. Next slide. So in addition to that is the complexity pieces, this growing health inequity issue, or the health equity or the health inequity gap that keeps growing. And this is very true for those who are living in lower incomes and living in deep poverty, those who are housing insecure, as well as homeless. Black, Indigenous, and other racialized population groups are also experiencing lower health outcomes. Women and other gender diverse individuals are also experiencing lower health outcomes. The next few slides, I'm just going to just show a little bit of some of the data on this. So this is data that I was able to retrieve from the Government of Canada on their 2019 publication on the health inequalities. And they give some very good summaries of what is happening in the Canadian population right now. So when it comes to one of the top 5 chronic diseases in Canada, that is diabetes, we see that prevalence rates are much higher for some of these very vulnerable population groups, for Indigenous population groups, for racialized population groups, for individuals who are living on lower incomes or who are living in deep poverty, those who are unemployed or in precarious employment, as well as those who have lower levels of education. We see that the prevalence rates are 2 times higher than the average population. And this again puts pressure on our healthcare system. In addition to that, when we look at the issue of self-rated mental health, onto the next slide, we see a similar pattern. We see that there are poor mental health self-ratings among these very vulnerable groups, including members of the 2S LGBTQ+ community, the Indigenous populations, people, again, who are lower income, and those who have precarious employment and lower levels of education. We see that the prevalence rates, if you look on this chart, range from about 2 to 8 times higher, depending on the priority population that we're looking at. And so there is a serious concern around this growing inequity gap that currently exists in Canada. And there is this very compelling reason on needing to find solutions other than the kind of solutions we've been currently looking at. If we look to the next slide, which is a little bit related to the mental health piece, we also see that on the hospitalization issue, that hospitalization rates are also much higher for these population groups, which can range from 2 to almost 4 times greater than the average population when it comes to mental health issues. So there is this compelling reason in the data alone that we're seeing. I thought I would share with you a personal example from my own agency, Street Haven. If we can go to the next slide. So Street Haven, if you're not familiar with our agency, is an award-winning women's agency. We've been around since 1965, and we actually are known for having established Canada's first women's agency, first women's shelter agency. We operate in the downtown east of Toronto, so in some of the most vulnerable neighborhoods, including Regent Park, St. Jamestown, Moss Park. And in addition to the shelter programs, we also operate supportive housing programs, training programs, and lastly, our residential addictions treatment program. There's only one of 4 residential addictions treatment program, and this is really focused for women who come into our organization and stay with us for 3 months, and they receive individual one-on-one as well as group counseling to help them towards their ongoing recovery journey. So this is a program targeted for clients who are interested in seeking treatment and want to move towards recovery. In our addictions program, I just wanted to give you a picture of the complexity of our clients. The majority of these women are living in deep poverty or on low income. Most of them are on social assistance. or aren't even aware that they're eligible for social assistance. We often have to help them apply for that. In addition to that, the majority, if not all of them, are survivors of gender-based violence and other forms of intimate partner violence. And this has resulted in issues around mental health and trauma, which is all tied in with their own usage around addictions issues. In addition to that, these women, unfortunately, also are all homeless. Most of them are homeless, around 80%, if not more, or housing insecure, in that they do have a place to go to, a house to go to once they complete addictions, but oftentimes it is very unsafe for them. And some of them are actually involved with the law. We do support the Ministry of Solicitor General in supporting corrections clients who literally come out of prison and go into our treatment program. So you can see that these clients are very, very complex in nature, and their complexity is more than just their addictions. It is about their history. It is about the social care aspects of their needs. And because they're so complex, providing treatment is not the only answer. And we know this because one of the data points we have collected is also trying to follow up with them and see what their death rates are after they leave us. I will say that our program has one of the highest graduation rates, and that is an important metric, although it's not really an outcome. It is an important metric for us because oftentimes, given the complexity of their situations, completing the program, just staying 3 months, the course can be very challenging for our clients. So we have one of the highest graduation rates. Despite that, our death rate over a 3-year period is 8 in 100. That is higher than the national average, the provincial average, and probably even the local, the City of Toronto average. So you can see the vulnerability in these women and how that plays out when it comes to their health outcomes. The reason why these outcomes look like that is that you can imagine if 80% of our clients are homeless, we give them treatment, they're committed to their recovery, and then once they leave our place after 3 months where they receive, 3 hot meals, a safe warm bed, support and treatment, and they're connected to healthcare providers and receiving advice and guidance on their personal goals, we pretty much say, okay, you're completed your regimen, goodbye, good luck. And they're either going to go into a shelter or go out onto the streets or go back into their very unsafe environment. And you can imagine why the health outcomes and their vulnerability towards death would be so much more significant. And this is the complexity that we are all in. This is an example of some of the most extreme situations, especially for women. So moving on to the next slide then is that in addition to this complexity is we're also seeing greater diversity in our population groups, whether it's in Toronto being one of the most diverse cities in the world. But not only are we seeing a more diverse population in terms of racialized populations, and that in the past 20 years, we actually grew by 130% when it comes to racialized population groups. And this is primarily due to immigration. We're also seeing a very diverse age group when it comes to social services and healthcare services. For the first time, we're actually seeing 5 generations in our care environment. And that's, kudos to, I guess, medical care, but also kudos a little bit to society and how far we've come. There's also that diversity around gender and sexual orientation, the vulnerability amongst women and the 2S LGBTQ+ community, and of course, Indigenous populations, one of the fastest growing populations in Canada as well. And we're seeing, and we're now perhaps not seeing, but we're beginning to acknowledge and recognize the impact of policies like colonization and assimilation on this population and how that's playing out when it comes to health inequality. So moving on to, just what does this mean in terms of having a very diverse population? Well, as many of you who are working in the field and who will soon be working in the field can imagine, this will have implications in the care environment when it comes to language, cultural competence, being cognizant of the impact of religion in the care environment, gender-based needs. Certainly for Street Haven, we're very cognizant that there are gender-based issues and needs that are particular to women and those who identify as women, age-related needs, as well as, and this is very critical in almost every vulnerable category, operating within a trauma-informed lens. And certainly we see that when it comes to supporting women and gender diverse individuals who've experienced gender-based violence, intimate partner violence, members of the BIPOC community. So all of this means that it does put pressure and demand on care, and that demands that the healthcare system also operate under a different lens, under an evolving lens because of this diversity. The last discussion I just wanted to bring up is this issue of the social safety net. So today's conference is intended to also target discussions around policy. And I will say that the health and social care systems are not operating optimally. They are fragmented and they are very siloed. And there's still much more work that needs to happen in those two systems. They operate separately, and the level of integration has not yet been optimally achieved. In addition to that, as a result of that, patients and clients have to learn to navigate the system themselves, and that can be very difficult. For us at Street Haven, we support a lot of newcomers, especially the refugees and claimants whom you all may have heard over the news and last summer. Our shelter is currently operating wherein 80% of our clients are refugees and claimants. And they require support in understanding our healthcare system, our social services system, our legal system. And that support is required. Otherwise, it would literally fall through the cracks and not be able to access the kind of benefits that they should be. In addition to that, the healthcare system is failing. We know that, we hear that in the news. There are long wait times, there are long wait lists. Millions of Canadians are not attached to a family physician, and that is a pretty scary thing. This means that we're kind of heading towards a bit of a crisis here, if not already. On to the next slide. So another key important thing to note is that this all didn't happen by accident, right? There's an element of government policy that is at play. So government commitment at the federal level, at the provincial level, and at the local level, their commitment towards austerity and austerity measures have resulted in this state that we're in. You know, the cutback in funding for critical human services like healthcare and social services have been cut down for decades since the 80s and the 90s, and we're kind of still on that trajectory. And this has actually raised concerns over the sustainability of the healthcare and social services systems. Will the system be there long enough for us when we're all older? Will it be there for our children and future generations? And that is a huge policy question that we're all having to face. In addition to that, because of the underinvestments, there is a large unmet set of needs that are growing in the population, and that health inequity gap continues to grow, and people are definitely falling behind. We see that on the streets, we hear it in the news, and certainly in my agency, we see it every day. And the concern is that it has become the new normal, and that is not something that we as care professionals should accept. So if I can send to the next slide, thank you. So the clock is ticking. There is definitely a sense of urgency. We cannot wait anymore as healthcare providers, as social care providers, as policymakers, as policy influencers, as decision makers. The time to act needs to be immediate. So if I can move to the next slide, please. Thank you. All right. So integrated care. I gave you a bit of a definition of what that is earlier, a bit of a long-winded definition, but there is significant literature that exists out there in Europe, down here in North America and elsewhere that have shown that integrated health and social care can lead to very positive outcomes. This includes the ability to identify unmet needs, both on the health and social care aspect. And I think, it's interesting. Dr. Shamji was talking about his work in the emergency room, that often the emergency room doctors will be, when they see the issue, they're dealing with a direct medical issue, they often are aware, as he said, that there's these unmet social issues that are driving them to the emergency room, to accessing the acute care in a way that it should be really accessed, right? The acute care isn't a place where homeless people should have to go because of social care driven related issues. Um, but unfortunately, that is what is happening. Integrated health and social care can also lead to enhanced healthcare access. And we have literature that shows that they can reduce emergency room visits, they can reduce the length of stay when it comes to going into hospitals, they can reduce wait times. They can also enhance client outcomes in terms of health and social care outcomes because clients are more better able to address their ongoing chronic conditions, for instance. It helps to address the complexity related to care. And I think one of the important aspects too is that there is greater client and patient satisfaction. And I think that's an important aspect. I believe that today, right now, what is happening, especially in the healthcare sector, there's such a like hands on deck. We're fighting fires. Let's just treat these people. And some of the issues around client satisfaction and creating a place that's more client centered has probably diminished a little bit. And that is because there's such pressure on the healthcare system. But we mustn't forget that it's important that we want our clients to be happy and satisfied even when they are receiving care from us. That is critical. So if I can move on to the next slide. So we know that with all of that is happening right now, that the biomedical lens is not enough when it comes to human care. In fact, COVID was unfortunately an involuntary collective human experiment that we were all involved in. And it showed in Canada that the healthcare system was not adequate to respond to this challenge of a global public health phenomenon. In fact, in Canada, it became as almost a social phenomenon, if you can imagine. I feel like if we all unfortunately remember those days of waves 1 through to 7, there was significant pressure on society. There were concerns about employment, concerns about job loss, concerns about precarity, the impact of COVID on women and precarious employment, the impact of COVID on older adults, the impact of COVID on homeless individuals, you name it, every corner of society was impacted. And it wasn't only a conversation about healthcare, it was a conversation about social care issues, about social issues. And so this huge social phenomenon, public health phenomenon, became really a spotlight about the social determinants of health, of why the social determinants of health is so important. And social issues got more of a spotlight sometimes than even the healthcare issue. Yes, vaccines were a huge issue, but so were issues about people who had lost their employment, who could not afford food. Food insecurity became a huge issue. And during that time, I remember I was working in the food bank industry. The demand just shot up for every single population group in the food bank sector. And it really highlighted how vulnerable these population groups are and how we as a society are very vulnerable. So moving on to the next slide. So there are some examples and conditions and factors that demand a really different approach. We know that the aging population demands a much more comprehensive approach. Those with mental health, the complexity of individuals with mental health challenges and addictions also demands a much more comprehensive approach. Individuals with comorbid and chronic conditions, people living in poverty, and those who are homeless, community members in the BIPOC community, and members of the LGBTQ+. These population groups are particularly vulnerable. Of course, women being part of that as well are particularly vulnerable, and we must address care for them using a more holistic approach. And that means integrated health and social care is a solution, one part of that solution towards enhancing care for these very vulnerable and high-risk client groups. If we can go to the next, sorry, is there a slide that says Street Haven example supportive care? I feel like we might have jumped a little bit ahead, I'm not sure. Is there something that says Street Haven? No, sorry. No, that's not it. Okay, sorry, must be it's been taken off. So why don't I share a little bit of Street Haven and how integrated health and social care actually can be translated. I think that's one question I get a lot as a researcher in this space. Like, what do you mean by integrated care? How does that look? How do we do it? And I thought Street Haven currently operates supportive housing. We actually operate low, medium, and high risk housing for high risk women. And our high needs supportive housing program, it actually houses a small group of women, all of whom are living in deep poverty. So they're all on social assistance. They all have comorbid chronic disease conditions. So they will have at least one or more of the following: heart disease, diabetes, arthritis, and sadly, even cancer. They all have a formal mental health diagnosis, schizophrenia being one of them, at least one of them. They're all frail, even though they're relatively biologically young. They all, unfortunately, because of their history of chronic homelessness, have lived a history where they have been subjected to violence and stress. And that, as you can see, as they age, actually translates into earlier onset of frailty. Despite their complexity of needs, these women are extremely well cared for, and they are able to successfully age in place. We are able to, as a result of our work, allow them to age in place. Many have been there for decades. They have been able to, they're all are attached to a family physician as well as a psychiatrist. And there is a very low incidence of crises, meaning that we hardly have to call the emergency services on them at any point in time, maybe once every 2 years, if even. That is unheard of when you think about the population we're serving. So how are we able to achieve these outcomes? We actually engage in very active integrated care. We engage in case management, intensive case management, where we have a file on our clients, we have a comprehensive assessment of them, and we work closely with all of their community-based health and social care partners so that they're attached to all of them. So all of our clients have a family physician, they have a psychiatrist, they have a mental health team attached to them. They also have close connections with their social services partners, including social assistants. And because of that, we're seeing these very, very positive outcomes. That's one way of translating integrated care. So if I can move on to a slide that says take note. Yeah, thank you. So before we actively upright, engage in integrated care, I think there's some things that we probably want to be mindful of. The first is that government policies around austerity can actually create a very toxic environment for partnership among community-based agencies, which can make integrated care very challenging. You can imagine if we're all chasing after the same pot of limited government funds, it makes wanting to be friendly more challenging for a lot of us. A lot of our community partners that are right out there in the exhibit hall, oftentimes we're chasing after the same grant on envelopes. And this can make us want to engage in strategic partnerships difficult because of this concern about chasing after this very small sliver of financial pie. Austerity can cause burnout. I was just talking to Diva about, the impact of what's happening in the healthcare system, and also in the social services sector, the sense of burnout, the sense of workload issues. We certainly don't want to create a pessimistic view for the very, bright and excited emerging professionals here today and in the exhibit hall. But there are these challenges that we cannot ignore in the social care sector and the human services sector. I think another key message I wanted to provide, and this is, there's these laws of integration that exist. They're called Litz's laws of integration. And there's really two laws I wanted to talk about. One is that whoever leads integration calls the shot. So if the healthcare sector leads integration, then they will call the shots. And probably will attack integration from a healthcare lens. If the social services sector is able to engage in integration and lead integration, then they will be able to approach integration from a more social services and social care lens. And I think that's very important. I've seen examples all across Canada and here in Ontario where there's a bit of both, and there's definitely a different flavor depending on who leads what. And if I may say, with without bias, because I am actually more healthcare trained than social services trained, that when social care sectors lead the integration charge, there tends to be a more comprehensive, holistic approach to care for the clients. And the other key piece I want to say, which is a little bit of a warning, is that it costs before it pays. Simply put, integrated care requires a lot of effort. You have to put in a lot of time to engage in partnerships, to plan, to do common assessment tools, to engage in team-based collaboration, to break down the barriers between health and social care partners, to have case conferences where all the different health and social care disciplines are operating more on a multidisciplinary and even transdisciplinary nature. That takes a lot of effort, and the outcomes may not immediately result. And so you need to stick to it, and the results will eventually come. And once they come, the benefits will be significant. So just to conclude then on the second last slide, integrated health and social care is the next frontier in the human services sector. We recognize that when caring for individuals, we have to look at the whole person. We just came out of this huge public health phenomenon, and I think it was yet another underscore on this issue. Given the evolving and changing nature of clients, the complexity of their needs, it's going to be an ongoing future in human care for all of us in this room. And the role of both the healthcare provider and the social care provider is going to be equally important. And we must challenge and break down those professional and sectoral boundaries and silos in order to achieve the best care possible. It will not help clients when you tell them, that's not my issue, that's the social services sector issue. Nor will it help your social services clients when you tell them, sorry, I'm not a healthcare professional, that's not my problem. Clients don't really care. They don't even know that there are boundaries sometimes. And if you can make them not aware of the boundaries and allow them to still seamlessly move through care, then you've achieved a level of integration. So with that, I wish you all a great rest of the conference, and I'm happy to take any questions.
Thank you so much, Dr. Sui. I think the questions will come in when we get into the discussion later. At this moment, I will invite Mr. Kasaija to come and share with us. We are going to skip the break because we have lost a little bit of time. What we are going to do is we are going to engage in these conversations, and then after that, we shall have an early lunch as opposed to going out for break now.
You're most welcome. Definitely, we will not stop appreciating your magnificent presence this morning, this afternoon, and tomorrow we shall still be here. So be here by 8 a.m. We shall be happy to receive you. We are not going to read his profile. He has a beautiful profile right here, but you all have these books, so you can be able to check it up and read it on your own. Thank you so much. All ears and eyes to him. Thank you.
Thank you so much. Good morning, everyone. My name is Joseph Kasaija. I'm a public health specialist by profession and also an incoming student for Masters in Public Policy Administration and Law at York University this fall. And I currently work with the City of Toronto. What I'm going to be talking about today is measuring the extent of building integrated healthcare systems in the Global South, as well as the Global North. And we're going to be having a discussion and a comparison to see which one is working and how best we can adapt it here in Canada. And it's just a brief presentation about the introduction, research methodology results, comparative analysis, and then a few conclusions. So I'll be as brief as possible. Next slide, please. So for this research paper, which is also still ongoing, I had to look at, I chose a few countries from the global south. I looked at Brazil, India, South Africa. And then in the global north, of course, I looked at Canada and USA. And I tried to have that comparative study and see how best, which one is working well. However, I have some quick facts. I was following Dr. Sumi and understanding what is happening here. In Canada, only 19% of primary healthcare staff frequently make home visits compared to 84% in the United Kingdom. We know in the UK they have the NHS, the National Health Service that they are using, but sometimes they can always borrow a leaf because even here in Canada we have free healthcare. But why are we failing? Why are we not performing to the best? And then here, this is showing that there's a lack. There's a lack in integrating the primary healthcare staff to work together with the doctors and other staff, and then to have that integrated healthcare system. 54% of Canadians believe encouraging health professionals to work in teams. So we don't want to have physicians working alone and they're not coordinating with social workers, people who are offering shelter, because these are all integrated. So if someone just goes and attends to a medical personnel for maybe they have a mental health challenge, they have stress, they have depression, and you just give them pills without addressing the challenge or forwarding them or working together with another counselor or even where they're staying. It may be coming from maybe a family dispute. So you giving them medication only will not be the solution for this. So we have to have that integration. And then back in 2018, there was 1 in 12 hospital patients had their stay extended because home and community care service or supports were not ready on discharge. So however much a client, for example, they had an accident, they came in and the orthopedics worked on them, and then time reaches, they need to go back home. They need to get well to the perfection, but they can be discharged from hospital. They may still need support, maybe a PSW when they go back home and they try to live their day-to-day life, or they need a wheelchair, they need an orthopedic maybe bed back home. They're trying to leave the hospital setting. So we still need like social workers, people who help them with the day-to-day activities. However, this has been lacking and it has been affecting quality of care. Lastly, 29% of primary care practices routinely communicate with case manager or home care provider about patient's needs when a patient is receiving home care services. And this was a survey from the Commonwealth Fund. And we still see, this is still showing the connection or the need of having healthcare workers, social workers working together, as well as community members and supports. So what I had to look at was building integrated healthcare systems, especially them being very essential in delivery, especially when I talk about diverse global contexts. Of course, I'm looking at the 2 cases as I'm doing this analysis. However, I just did something what we call a systematic review of literature. I was trying to look through different papers which have been published, and I looked at the policies which are affecting implementing this, and then quantitative metrics, of course, supplemented by qualitative insights. I should, however, say for this specific research, the challenge I found, or something that really challenged me, is I reached at a time and I asked myself if I could get access to certain databases where you have to pay, or the government database that you cannot access if they have the information that I needed. Of course, I could not do focus group discussions, especially with those police people or the main decision makers that implement this integrated healthcare system. However, I highlighted a few challenges, opportunities, and lessons learned, providing a comprehensive understanding of the healthcare system integration across socioeconomic landscapes. So this is a comparative study, and we're trying to look at how we can build this integrated healthcare system. So between the global south and the global north. We should also agree, yep, thank you. We're on introduction, next slide, please. Yeah, healthcare systems globally face complex challenges. We all know that, and it has been made clear since we started here. However, having the integrated healthcare system, and this you need to understand all aspects of the healthcare approach. If we're talking about infrastructure, we're talking about funding, we're talking about policies, we're talking about the healthcare workforce. And then we're also looking at the community, how it comes in, how we are working together. And in this specific one, and just provide comprehensive analysis of this healthcare system integration and the methods, the methodological approaches, and then the results of the economic, socioeconomic context. Next slide, please. So one of the things I did was to go through the methodology. I did a systematic review of peer-reviewed literature, policy documents. Some were not accessible, but I tried to go through different channels to make sure I get them. And then what I was looking at, I was looking at the components of the integrated health system for each country. In each category, then the metrics and methodology used to measure this integration, the challenges and opportunities for each health system integration, and then the comparative studies and lessons learned from the different regions. The other thing is I try to look at the quantitative analysis, and this research paper, I'm still, every day I think about it, the more I think of adding more knowledge and more research. So it's still ongoing, and hopefully it will be published one day, one time. So I also looked at healthcare access utilization in the different healthcare systems, and then the health outcomes, trying to see the key health indicators such as mortality rates, disease management outcomes, and patient satisfaction scores, which were provided by these websites. However, of course, we know sometimes there's bias in reporting by different countries. And sometimes you try to go to the World Health Organization database to see if at all they're kind of, leveling up together. Also, I had to look at the cost effectiveness because financing has been a big challenge. In Canada, we have healthcare, which is free for all. However, there are still certain services which are not available for free to certain people that either have insurance or a private insurance or something. So that means cost effectiveness. I think most of us have had the challenge with dental. I've seen the government trying to push funding to have dental access by seniors, and it's a good drive that they're trying to push it, especially most of them are having these challenges. And what I looked at here was national health surveys, administrative databases, healthcare utilization statistics, and then from relevant agencies and healthcare providers. Can we move on, please? The other interesting one was policy analysis. Just as I said, I've been working in policy for more than 10 years. And one of the reasons why I'm going back to school to add an additional master's in public policy, of course, to understand the context of Canada and more of the global north, and also working in municipal level, is a lot of challenge that I see certain policies not going through, and reasons sometimes why they're not being implemented. You can always laugh and wonder why, and all the bureaucracy. So I had the chance to look at certain policy documents from government and non-government organizations to understand the regulatory frameworks, which are very important, incentives, and then barriers influencing this integration of the healthcare system for each country. And one of the things that I really looked at that caught my eye was funding mechanism and financial incentives. We know, like in Ontario, we have our own health insurance. However, for newcomers or asylum seekers, those still have access to the federal health insurance. So I'm trying to look at the difference, which one even offering more services compared to the other. Then the government structures, of course, politics plays a role. And then the regulatory frameworks, the guidelines, the laws, and all that. And then finally, I also looked at the initiatives promoting healthcare innovation and digital health adoption. Right now, we're in a digital world, and I've been surprised that most countries are now, even in the global south, are trying to integrate everything into digital. So I talked about the study limitations. Of course, I talked about accessing qualitative information, especially from certain stakeholders or government institutions. Databases was a challenge. However, I'm going to present a few results of what I saw. For example, one of the countries in Brazil, remember this is a comparative study. I saw there was unified health system. Here, of course, we call it like healthcare for all. But the reason why they're doing that, they are making sure to increase coverage and expanding community health services, but as well as integrating it together with clinical care. And then there was also the family health strategy, because most times health begins from home. So they're trying to promote multidisciplinary care teams to enhance on care coordination and disease prevention at community level. We have community leaders, we have social workers, reaching out, as well as working together with the doctors and clinicians. The challenge they had was funding, regional disparities in healthcare infrastructure. Some places had better hospitals than others. Others had more funding. Others, were not accessible. And then the administrative complexities. When I looked at India, they have what we call the National Health Mission, which has been increasing access to healthcare. Because remember, we have access, and then you might have access, but you don't have people even utilizing those resources or services. So the other thing that they did was public-private partnerships. However much we have challenges, so they were trying to engage private sector to come play a role in providing healthcare. The challenge they had was the fragmented healthcare delivery, the inadequate healthcare workers, we all know this one, and then the disparities in healthcare. When I went to South Africa, of course, we're seeing they also have the National Health Insurance Plan, which is proposing to achieve universal healthcare. They are on plan to achieve it. And then they also integrated the community health workers to mobilize them to improve health literacy amongst communities. The challenges they had was socioeconomic inequalities, given that South Africa has a different kind of race thing going on and social structures. Then we also had the burden of disease and then the resource constraints. Next slide, please. Then I came back to Global North Canada here. We have the healthcare system we all know about, the universal public healthcare coverage under the provincial, emphasizing public healthcare network. It's a good thing. However, it still needs more work to be done. Then we also have digital health initiatives, especially investing in electronic health records, which has tried, like when you're at your family doctor, by the time you go to the laboratory or to the pharmacy, your information is already there, which is okay. The challenges we have here is interprovincial variations. What we have in Ontario is different from Alberta. So if someone is moving across these provinces, there's a challenge. And then funding constraints, and then gaps in healthcare among indigenous populations. United States, we have what we call accountable care organizations, which have been promoting care coordination and quality improvement under the Medicare and Medicaid programs, which have been promoted by the presidents. And then we also have integrated delivery networks. These are collaborative networks amongst the hospitals to work together. But the challenges, of course, we are seeing they have fragmented healthcare financing, disparities in healthcare access, and regulatory complexities, integration and sustainability. So as I come to conclusion, we need to address the challenge like healthcare financing and then regulatory hurdles, because these are the most challenging issues amongst both Global South and Global North. However, we need to work together with decision makers. And then there are opportunities to promote value-based care models and strengthening healthcare data analytics capabilities. And by understanding the notions of healthcare integration, efforts in the Global South and Global North, policy makers, healthcare providers, and researchers can identify effective approaches to enhance healthcare delivery, improve patient outcomes, and achieve sustainable healthcare systems globally. And the certain themes I looked at, so the common themes that came up, there was care coordination, health information technology, then the policy changes. And I think with that, I want to thank you for listening in, and I'll be available for any questions. Thank you very much.
Thank you very much, Joseph. You've done us so much good. How are you feeling right now? I just want you to feel yourself right from the head up to the toes. How do you feel? Do you think we are taking in something? Do you think that if you had stayed home, there was so much for you to miss? That is lovely. Now, can you stand up for a while? Just stand up, just a little bit. Shake your body a bit, just a bit, just a bit. Oh yeah, oh yeah, oh yeah. We are grateful for this body, right? Mm? Well, very quickly, before I invite our next speaker, I have written down the word humans, and I would like us to break it down very quickly in relation to health and social. Very quickly, what could H stand for? Very quickly. I need fast thinkers. H, health, very good. Any other? H, house, household, happiness. We have to be happy with our health. Okay, let's go to you very quickly. What would you stand for as far as medical and social is concerned? Unity, lovely, beautiful class. Which other? Come on, quickly. Universal, lovely. Another one? English class. Uniform. We all have to put on uniforms when we are going to work. Yes, healthcare takers have to be very understanding with us. Sometimes we can be very notorious patients, not so. Okay. What does M stand for? Very quickly. Medical, lovely. Medical, beautiful. Any other M here? Mind, yes. Mind. My daughter, someone says. Lovely. So we see where a father's heart is. Money, yes. Money. So very important. Thank you very much. You love money, don't you? Any other? Yes, lovely. Men, very important. So we need men in our healthcare. Sometimes they're more friendly, not so. So the ladies prefer to go to the male, you understand those things. Letter A, that's where my mind was blown up. Humans, we are into humans, breaking it down in relation to medical and social. Addiction, lovely. We get very addicted to work, to substance, to anything. We have to check our addictions, right? Any other A? Availability, ambitious. This was a very extremely ambitious conference. Access, we have accessible health centers. Any other? Affordability, yeah, lovely. You see how that connects? That is our A, letter N. Humans need, we all need a shoulder to cry on, right? We need healthcare, we need social work. Are we together? Another knee, N. Neat in our uniforms as we go to work, neat in our brains so that we don't yell at the patient. Any other N? Nature, lovely. We are natural beings. Do we have any other N before I go to S? Okay, let's go to S very quickly. Sorry? Special, service, social, support, sustainable, system, Susan. Okay, lovely. Wonderful. You can take your seats right about now. Thank you so much. That was really brilliant of you. Thank you. Okay, at this point in time, we are going to invite another speaker who is also going to take 15 minutes. And it's going to look at the unpacking the theme health in a social perspective with focus to integrated care and mental health. At this point in time, allow me to invite our friend, our person, someone whose office we enjoy to go to. That is none other than Dr. John Wasiche Chiria. Kindly clap for him as he arrives. Thank you so much.
Okay. So glad to be here. I'm very glad to be here. My name is John. I also go as John K. I happen to have a background training as a physician. I'm currently working with the City of Toronto, specifically in sexual health promotion. Mine is just unpacking. It is just contextual. So if anyone is looking out for any academic context, you're not going to find that today. That would be in the classroom. I also hold a master's in public health, and so my background is relatively informed. There's a PowerPoint which I prepared. I hope it can be. Sorry about that. It's going to be quite hard for me to go ahead without the PowerPoint. No, that's not it. Any other way I can share it? Share.
If you're happy and you know it, clap your hands. If you're happy and you know it, clap your hands for me. If you're happy and you know, and you really want to show it. If you're happy and you know it, clap your hands. If you're happy and you know it, say I am.
I am.
If you're happy and you know it, say I am with a smile. If you're happy and you know, and you really want to show it to me. If you're happy and you know, say I am.
I am.
If you're happy and you know it and you have a firm shoe, stamp your feet. If you're sure that your shoe will not break down, stamp your feet for me. If you're happy and you know, and you really want to show it to me. If you're happy and you know it, stamp your feet. If you're happy and you know it, give your friend a high five for me. If you're happy and you know it, give your friend a high five for me. If you're happy and you know it, and you really wanna show it. If you're happy and you know it, give a high five. While we wait for Dr. Cheerios PowerPoint to get on, give me a smile. If while we wait and you're happy and you know it, give me that smile for me. If you're happy and you know, and you really want to show it, we had to sing for it to come. If you're happy and you know it, clap your hands. Lovely. Thank you so much. That was good.
Thanks a lot, Susan. And that is the end of the presentation. I really appreciate. Okay, so we are going to be looking at health in a social perspective, integrated care, and mental health. And I'm really going to try to unpack what integrated care, access, and for healthcare providers, the complexities that are there around what we construct as healthcare. Let us look at the next slide. And we're going to really start with a conclusion. Just in case the fire alarm goes off and we have to leave here or someone has to leave, I don't want you to leave without the main message. So we are going to look at three main tenets during these next 5 to 7 minutes. And we are going to look at the intersectionality between the values, the attitudes, and beliefs, and how those affect the professional standards, the policies, and the law, and how that eventually affects what we construct as care. And even when we look at care, we're going to look at the care of the client, but we should also be cognizant of the care for the care provider. So by just looking at those three, if we can just conceptualize that a little bit, we should really be in a good place to conclude. So patient care centers around acknowledging and respecting and integrating and incorporating the patients, the clients, or the care providers' values, attitudes, and beliefs. And we're going to unpack that a little bit. So even when we talk about a client, even when we talk about giving care, have we looked at all these pieces? What is the individual's value? What is their attitude? What is their belief? Because even when we look at a client, when we look at disease, how do we even define disease? And that can really determine whether a client even shows up to your clinic. How do we even define power and power dynamics? And who are the custodians of healthcare? All those are critical pieces. Who is the first and primary contact when someone thinks, believes, or knows they are unwell? What about the value, the attitude, and belief of the healthcare provider? Can that be a barrier to accessing care? So I'll just go through one scenario and then we shall come back to the rest of the presentation. But at the end of the day, let us look at this. What makes Canadians healthy? And this is available online. So this is a story about Jason. Jason shows up in the hospital. Why is Jason in the hospital? Well, he came because he has a bad infection in his leg. Oh, just like Honorable Hamji, doctor, said earlier on. But he has a bad infection in his leg. Why does he have an infection? So we are now moving backwards, right? Because he has a cut on his leg and it got infected. But why does he have a cut on his leg? Because he was playing in the junkyard next to his apartment building, and there was some sharp, jagged steel there that he fell on. Playing in the junkyard? Why was he playing in the junkyard? Well, that is because his neighborhood is kind of run down. A lot of kids play there and there's no one to supervise them. So, why does he live in that neighborhood? Because his parents cannot afford a nicer place to live. But why can't his parents afford a nicer place to live? But his dad is unemployed and his mom is. But why is that? You see, this is the narrative that we are interfacing as care providers. We have so many band-aids. We are looking at someone without acknowledging the circumstances. And that is where I have finally acknowledged that healthcare is really just a social construct. It is no longer a clinical issue. So when we look at the trajectory, when we look at the evolution, when we look at the origin of healthcare provision, initially, ages back, when there was smallpox, it killed millions of people. We moved from the time that the vaccines were introduced. Eventually in the 50s, the antibiotics were introduced. And as we moved along, we started looking at physical safety. It was make a seat belt, a helmet, a knee pad, an elbow pad. We're looking at physical health and safety. And then we evolved to behavioral. We started looking at, have you gone to the gym? You should exercise. You should not drink alcohol. You should not smoke. And the whole piece was an evolution. And it was moving towards behavioral. We are now moving towards the mental component. And when you look at the cost of being mentally unwell, you know, how many of you have called in sick and you're like, hello, this is John, you know, I'm not able to come in today because I'm feeling unwell. There's this notion that physical ill health is the only explanation or justification for you to not show up at work. What if I said I am stressed? Because technically, mental health takes up more time off. If someone has got a mental health challenge, they will probably be off work for weeks on end. Whereas a cough could be 3 days. So how come we feel we have to cough and exercise this whole notion that we're very unwell? So let us move to the next slide, please. How many of you have heard about the healthy immigrant effect? Let us ponder about this a little bit. It's actually, I implore you to read this. The healthy immigrant effect is the term given to the phenomenon of immigrants arriving to Canada. Many of us are immigrants here, with stronger health than their Canadian-born counterparts. Isn't that concerning? Isn't that surprising? Because we migrate here looking for a better life, but there's an acknowledgement, there's research, there's evidence that we come here when we are healthier than our Canadian-born counterparts. Ironical. But it only gets, I won't say better, neither will I say worse, I will say complicated. It gets complicated because immigrant health experiences a steep decline over time from the time they migrate. And they get to the same level with the Canadian-born counterparts and tend to even go lower. So as healthcare providers, we should acknowledge that when people come here, there's something they have always been doing that was placing them in a better health situation, and that when they get here, there's a tendency for them to either not do the same things or not have access to the same resources. And that will therefore explain for. So let me go back to my country of origin. When you go to the bathroom, you just might find a pit latrine. And when you get there, you sort of have to squat over that hole. And I don't know how long you're going to be there, but you bet you're toning your thighs. Every time you go to that pit latrine, you're toning. When we come here, we have magazines in the toilet, so we just go sit down. And for those who are really unhealthy, we also go with our phones and we scan while we're on the toilet. Multiple problems there, but that's not the discussion today. When we are taking a shower, even when there's a bathtub, we usually have a basin in there with water, and we are flapping water over our shoulders, and we are working the upper hands. When we are preparing our food, we are using a mingling stick with that cornmeal, and we are working our upper hands. When we get here, they say in Canada, everything is done using a finger. It can be interpreted and misinterpreted, but when you turn on the car, you use a finger. At the elevator, you use a finger. The washing machine, you use a finger. So literally everything. Whereas at home, when you wash your hands, you actually wring those clothes before we put them over the clothesline. So you can see how our lifestyle here changes. I've got a whole whack of kids at home. I've got only 4 so far. 3 of them are teenagers, but they are going through a whole whack of food every single day. When you look at their lifestyle and what my lifestyle is or was, it is totally different. Their health and how they live their lives is different from mine. So when we look at the healthy immigrant effect, when we get here, what have we changed? And how do we access services? If you are a service provider, do you acknowledge that people come here when they know better about their lives? Our children eat peaches, prunes, pears, strawberries, raspberries, blueberries, and I don't know what other fancy fruit that I cannot comprehend. I know mangoes and pineapples and sugar canes and guavas and jackfruit. Jackfruit. We really have to move along. I've got only 15 minutes and I think I've already gone through more than half the time. But when we look at a new immigrant coming here, all of a sudden our diet changes, because the fruit that we are used to eating is not the same fruit we have here. So it is simplistic for us to tell someone you need to eat healthy. If anyone won $1 million today, the breakfast they will have tomorrow would probably be different. So the difference between my meal today and my meal tomorrow could pretty much be finances. For you to be telling me what to eat is condescending, is not acknowledging, is not recognizing that I have an idea how to live my life, but I'm only going through constraints. Let's move to the next slide. I really could hover around this all day because there's a lot we could talk about it. Definition of ill health. So sometimes what we construct as ill health in this country is totally different from what is constructed as ill health for other people. Just because we say there is a service doesn't mean it is accessible. I'll just go back one and I tell you how deep culture and history can be rooted. How many of you got your COVID vaccines? And I'm not asking that you put up your hand, but at the end of the day, I was working with COVID-19 response during the pandemic. We were giving you results. We were booking people to go for their vaccines. I, John, working with Toronto Public Health, did not schedule my appointment. I walked in. I scheduled people to go for their appointments, but deep-rooted in my culture and my being, we don't make appointments. So I just showed up and I stood in line for half an hour, for 45 minutes, and the people who had booked an appointment went 2 minutes, 3 minutes. And when I went for my next vaccine, guess what? Did the same thing. So every time we say book an appointment before you come, guess who is not going to be able to make it? Because it is deep ingrained in my DNA. So as service providers, we have to think about accessibility as being something more than free. Just because I have an OHIP card and the vaccine is free and it's available doesn't mean it's accessible. My core being is not aligned with some of the way the systemic structures here have been set. I'll move to the next, not yet. Definition of ill health. 2 examples. In our culture, a woman is in her 50s, she starts getting vaginal bleeding when she's in her menopause, and they tell her, oh, you're getting young again. Usually that is an indication of a problem with your cervix, and it could be even cervical cancer. So we have a problem that what you're defining as ill health, actually for me, is not ill health. When we talk about female genital mutilation, circumcision, and what, some people do not define it as a mutilation. It is just a procedure. It's just a cultural component. When someone goes and they go pee, especially for men, and they take a long time peeing, they're getting the dribbling, it is constructed around maybe someone was promiscuous. So then they do not disclose. So we are dealing with clients who are not aware of the definition of illness, or we have a different definition, and then access is based on that. When we look at the cause of ill health, a lot of people are having different definitions. If someone says that this is a cultural thing, then they are not going to show up. If someone says this is a spiritual component, then they are not going to show up in the healthcare system. So how we define the cause of an illness is also going to determine whether we come for care. I'll just go slightly into perinatal or prenatal access to healthcare. Generally speaking, many cultures from back at home, the first point of care when you conceive, when a woman conceives, they rarely tell their husband. They usually first tell their mother or their mother-in-law. So how come that is what happens? Well, the notion is if you tell your husband you're pregnant, the clock starts ticking. If 9 months later you don't have a baby, then we got a problem. This woman has miscarriages. Maybe I should get another wife. So the wife is not going to disclose until she is sure that she's carrying the pregnancy to term. And therefore, coming for antenatal visits in the first trimester is minimal to none. So we got a problem that women are showing up for the first time when they're 6 months pregnant. the family structure and the constructs. The first contact. If I'm having a relationship problem, the first person I speak to is my spiritual leader, not my doctor, not my social worker, which means people are going to come in late stages with depression, and some are even going to commit suicide. So when we are defining all these components, as care providers, we have got to acknowledge, embrace, recognize the values, the attitudes and beliefs, and how they influence how we access or not the services. Treatment need or effectiveness is also another component. If I believe my challenge is spiritual, then why are you giving me any medication? Because clearly what I need is a prayer. So what is your treatment need and how effective is it going to be? Power, perceived power, and dynamics. Again, we talk about that a lot. In my experience as a healthcare practitioner, as a physician, I can count on one hand the number of times a male client came to me alone. Pretty much every time there was a female who came with them, either their wife, their sister, their mother, on rare occasions, their colleague. And how is that? So that means when I migrate to Canada and I come alone and I do not have a significant female holding my hand, my chances of accessing the healthcare are going to be diminished significantly. As a care provider, are we cognizant of these issues? Let's move to the next slide, please. So the vulnerability paradigm of the client care. Power, perceived power of care provider, I just alluded to that. Information withholding. I could talk about this forever, but clients withhold a lot of information. You really have to pay attention to your clients when you're taking care of them. We had a scenario one time where there was a lady who was HIV positive. And we were telling her that, you should not breastfeed because breast milk could affect the baby, could even infect the baby. But in exploring what her biggest challenge was, she said, my biggest fear is my mother-in-law is coming. How am I going to explain why I am not breastfeeding? This is someone who is HIV positive. They are expecting a baby. They should be excited. They have access to care. They have access to resources. We are their service providers. And of all concerns on their list, the visit of the mother-in-law trumps them all as a care provider. And that is why I say that really healthcare is now a social construct, because at the end of the day, whatever you say, whatever you do, if you do not have a deep understanding of your client's challenge or potential challenges, then you're not going to have compliance. They're just not going to do it. I didn't want to forget about the antihypertensives piece. Again, this is a conversation we shall have during break. But you see, a lot of men start getting erectile challenges or dysfunction. When you take your antihypertensives, sometimes they act by relaxing the muscles, which means the erection is not really as strong. It is a common practice for men to skip their medication for high blood pressure if they are planning to have intimacy. If you as a care provider do not know that, then You're just going to keep upping the dose. How come this person, their blood pressure is still high? And you just give them a little more and a little more and a little more. And they're withholding information from you because you come up as elitist, as power driven, as an enforcer. And so they do not disclose to you. And you unknowingly treat them wrongly. If you're not accessible as a care provider to listen to those conversations, then you can never be effective. Let's move to the next slide. Duality of identity. I would like to spend a little time on profession, standards, and law and policy. As a care provider, we are really seated on a time bomb. Because you are a registered nurse, you have policies by the Registered Nursing Association of Ontario. You are also an employee for the City of Toronto, and so there are policies at the City of Toronto, and you have been invited to go and do some work at a long-term care home, and there are some guidelines there, and then, or maybe at a daycare. And so now there's a scenario that has come up about a child, and you're like, okay, the city says this, the Nursing Association says this, but the daycare says this. As a service provider, you have got to look at the duality of the guidelines and the policies and your vulnerability should you not adhere to one of them. So there's the complexity. Now we have ongoing conflict in our head and we are getting all tense every time you're going to speak. Every time you're going to work, every time you're going to serve, you're like, I hope I don't get in a situation where I'm vulnerable to the point that I can lose my license or lose my job. So you can see, and we can talk about duality of identity. So you are a registered nurse in Canada, and now you're getting a job to work in the US, but you just happen to go to that state where abortion is illegal. And your license in Canada says you're going to support it. So how there's that duality of identity. How do you balance those? And how does that affect your mental health? Empathy. Ironical. Empathy is actually a risk. I wish we had time to spend more time on this. Every time you empathize, you put yourself in the situation of that individual. You become technically vulnerable. So someone comes and tells you, I was assaulted, intimate partner violence. And for you to empathize, you have to feel like you are being assaulted yourself. And that person leaves and another one comes and says, my mom died last night. And then you empathize with them and you start grieving as well. And then the next person comes in and says, you know what? My child just fell at school and has now been admitted in hospital and their leg they're in intensive care unit. And then you empathize with that person as well. And then the next one comes in. And by the time you have gone through your day, you have empathized so much. You are so tense. You are so overwhelmed. And that is what the definition of vicarious trauma actually comes from. That is very similar to post-traumatic stress disorder. The difference is you're not there physically. But we are in Afghanistan every day. We are in Iraq every day. In the psycho, social, emotional, spiritual realm. Because we are interfacing with clients. And if you truly care about your client, then you are empathizing with your client. And if you're empathizing with your client, then you are truly vulnerable. And if you're truly vulnerable, then you really need care. And that is where now, as care providers, we have to think about how all these pieces come together. We're running out of time, but there we see, we get emotional about empathy. Empathy is a risk factor, big time. We could spend a whole day talking about that, but let's move to the next slide. So, care provider resources. I'll just comment about the bottom picture there. At the end of the day, there's the intersectionality between what we construct as our culture, what we construct as spirituality, and what we construct as clinical services, especially when they come to mental health. Many times someone will come to you and they will tell you, what I'm experiencing is a cultural thing. Sometimes someone will tell you this is a spiritual thing. So then you go to your imam, you go to your spiritual leader, looking for help, looking for support. There is one young lady who actually died when they were in a place of worship. This young lady got an asthmatic attack and collapsed. And then people came around her to pray for her. And the more they prayed, the worse she became. And the more people came to pray for her, and the more congestion there was, and the less oxygen there was, and the more suffocation they had. And eventually, by the time they decided to go to the healthcare provider, the girl did not make it. So, am I saying there is no place for spiritual support? I am actually saying by the time you migrated to Canada, for those who migrated or those who are caring for new immigrants, we need to find out how did they do it? Because there's something that was working for the new immigrants before they showed here. And until and unless we explore what it is that they used to cope, we shall be left unknowing. It is ironical that you can have a wait time in emergency room. It is ironical that we have a shortage of doctors and you can wait to get a family physician and you can wait a whole day. But try getting mental health support. Try getting a counselor. Before you get a counselor, before you get mental health support, before you get a psychiatrist, you need to first go see one of those doctors that you cannot see so that they give you a referral to get to the psychiatrist or the psychologist that you cannot get to. Good luck. When we look at some of our social, cultural, and spiritual supports, our spiritual leaders have actually been very helpful, very instrumental in dealing with some of the attributes of our coping strategies. And if that be part of them, so be it. With the caveat that if it's not, then it is really a treacherous path. So when we talk about availability, when we talk about accessibility, we have to acknowledge diversity. We have got to acknowledge whether that service is actually tailored to your persona. Because if someone believes that this is a spiritual component and they go to someone who has no acknowledgement, acceptance, or understanding of spirituality, then they are going to hit a dead end and they will not embrace it. So let us acknowledge that there is a multifaceted approach and that people generally have a coping strategy that is inherent in them and that they can identify what those are. As care providers, let us ask those questions and let us also make the referrals which are appropriate when we so identify that that is what they need. Or HIP covers psychiatrists, upstream thinking, and then we are wrapped. Next slide, please. This is a story. If you haven't heard about this story before, please explore it online, read it up. Upstream thinking. The notion is that many times we put all our resources at the clinical care setting. So in this pictorial, kids used to be playing right at the top of Niagara Falls and they would fall in the water. So at the bottom, they had the ambulance, they had the floaters, they had the CPR, and all the medical personnel were at the bottom. The rescue team was becoming more and more efficient. And so one time, a lady came and said, how come you have all this operation here. And they narrated how great it was, the alarm systems which went off, and the ambulances and the fire trucks. And then they said, what about we go up at the dam and we put a barricade so that the kids can stop falling down the falls. And lo and behold, they did. And then the people at the bottom, the ambulance had no one to take around. So when we go upstream, that is the public health approach. We are saying that when you go upstream, that is pretty much prevention. Everyone, and I really appreciate when Susan told us to stand up and we had some singing, we really need therapy. The care for the care provider cannot be underestimated. You can only care for someone when you are well. If you care for your clients that much, take care of yourself. It's the best thing you can ever do for your client. Taking care of yourself. I think we have the last slide. Oh. Yeah. I remember we were here sometime earlier today. I would like to conclude at the same note that patient-centered care primarily is about self-care. It will acknowledge, respect, incorporate the patient as well as you, the care providers, history, your experience, your values, your attitudes, your beliefs, and even your preferences, with the understanding that we shall not be discriminatory, we shall not be judgmental, we shall not be intrusive, that we have got professional responsibility over and above our personal identities. Thanks a lot.
Thank you so much, Dr. Wasiche, for a very lively and provocative presentation. We truly appreciate your knowledge sharing. I wonder how, and as I continue speaking, I think I'm going to invite all of the panelists to come here for another broader discussion. I'm pretty sure people in the congregation do have some questions to pose to you. But as Dr. Wasiche concluded, I wonder how we talk about, you can come and sit here. We talk about, or we incorporate the ideas of equity, diversity, and inclusion in relation to healthcare and social work. And I think we shall definitely engage in that conversation as we continue this conversation. Please prepare your questions as well. I'm going to be joining these incredible humans to engage in a much more, to dive deeper in some of the issues they have highlighted as we engage in this conversation. And of course, I'm going to start with Dr. Cheng. Thank you for providing the deep analysis on some of the findings that you have found in your study, and especially founding the Street Haven. Thank you. My initial question is, to what extent, in your opinion, to what extent has Street Haven succeeded in addressing some of the social policy issues within our communities? Issues such as poverty, homelessness, food insecurity, which is also, by the way, one of my key interests in my research. mental health issues, and most especially, how do you think, as we engage in these conversations with other partners that are in this room, what are some of the recommendations that you make that we should do to minimize the impact of austerity in relation to how we relate with each other, especially in regard to the conversation right now, healthcare and social work?
I mean, I think those are really big questions. So maybe I'll tackle it. I'll start off with the first half, which is like how we're dealing with some of these bigger, broader social issues. So as an agency, I'll speak to how we're dealing with it on the ground, the issues of food insecurity, housing insecurity, poverty, women's issues. All of these issues are intersectional. They're playing right at that point of intersectionality. And I think one thing we haven't touched on as much so far, I mean, mind you, it's only been the morning, but the refugee crisis is alive and well right now in Toronto. Summertime's coming and we're expecting a lot more refugees and claimants to arrive in Toronto. We saw that last year. We were in the thick of things. And I think I was telling someone here today, we went from a shelter that used to serve maybe 30% refugees and claimants. We're now at 80%. And at one point we were at 90%. And in the course of like 6 months, we actually started counting how many women we were turning away because we were so at capacity, we could not serve more women. And yet women who through word of mouth were like knocking on our door every day and like crying when we had to turn them away. And John, I have to say, like, thank you about the comment about self-care, because the folks who work, or women and other individuals who work in the shelter system, it's a very stressful environment, right? Like the cumulative trauma cannot be dismissed. And for the women who are working in my agency and other individuals, for them to turn away 600 women in the course of only 4 months, it's very, very stressful and traumatizing because they'd never turned away that many women in such a short period of time. In 1 year, we serve about 600 women, especially with the housing crisis taking place now. How are we dealing with the issues of food insecurity and housing insecurity and all that? We actually have broken down our own barriers inside our own agency. We have 4 big program streams, or we have 4 program streams. And I've really challenged my management team to break down their silos that, just through natural development and evolution of the programs have existed for a while, and really work closely with each other to say, those addictions clients, they also benefit from supportive housing supports. They have to eventually go out and find homes, get them early, try and get them, work on the intensive case management before they even leave us so that they might have some place to go to after they get discharged. As I mentioned, our death rate is 6 in 100 over a 3-year period. That is pretty scary data. That's not the kind of, like, as you know, John, those are terrible death rates, right? Like, they are not good. And with regards to the food insecurity, we actually do provide food in all of our shelters and for our supportive housing clients. So we make sure that we plan out the healthy meals and those sorts of things. And one other critical part is that we have engaged actively with all of our community partners, both on the health side and on the social side. We actively reach out and try and look for more enhanced benefits and supports for our clients, so that if we don't have the expertise, and we don't pretend that we have expertise in everything, we will form partnerships with other agencies, whether it's the Gerstein Crisis Center or hospitals or the ACT team or withdrawal centers, and have them kind of coordinate this care so that it's seamless. We use the term soft handoffs, right? That the clients or the patients don't even see that this transition is happening, more or less. So on that side of things, that's how we're operating. We're operating under a very strong integrated health and social care lens that leans heavily on our partnerships in the communities, but also leans heavily on our own internal strengths. So it comes from a very strength-based approach. So let's move on to your comments about, some of these big policy pieces. So as a small agency, we're actually one of the co-founders of the Ontario Women's Coalition for Supportive Housing and Shelter System. And we come together as a series of agencies from across Ontario, representing the North, even the Greenbelt, and Ottawa, and a few other areas. And we kind of come together and talk about these big issues that are impacting the women's supportive housing and shelter system. And we engage in pretty active advocacy at the local, provincial, very much provincial, and the federal level, trying to urge more investments in housing, supportive housing, women's issues, mental health, and primary health care. That's one area where we're trying to tackle this issue of austerity as a small agency, but also, this kind of leads to the advice of so how do we tackle austerity? Well, I think it's in all of us as individuals, as individual agencies, to adopt the feeling or the attitude or the belief that advocacy is core to your job. And not just the advocacy you do on behalf of your clients, but advocacy that you as a citizen or as an individual who lives in Toronto has that ability to do so. Call up the MPP. Shamji just showed up. Tell them what's on your mind. Call up all of your MPP's office, the local ward councillors, your MP offices. Tell them that you have very serious concerns. That's what we do. We have taken a very strong advocacy stance at the agency. That's something that, if anyone wants to listen to me, I will tell them until they're, tired of listening to me about some of the critical concerns that currently exist when it comes to investments in women's services, around food insecurity. Like just recently, the City of Toronto told me, because of austerity, hey, Sumi, remove that extra budget on food because those clients that you're feeding who come to your door, because they're not shelter clients, even though they're the refugees and claimants, they're not our clients, so we're not going to support you in feeding them. And I just have to tell you, from a human rights perspective, from a woman's perspective, from a social justice perspective, I was so outraged that I just started sending emails and talking to whomever would listen to me, that I personally found that outrageous. Like, this commitment to austerity really it doesn't make sense against our desire to continue to advance social justice and basic human rights. But these are the things that we as professionals, as leaders, as providers, we have to feel responsible about this collective sense of social justice when it comes to advancing public good, and that we each as individuals have a role as well as our respective agencies. So.
Thank you so much again. On that note, you want to respond as well? Oh, okay. Yeah, so on that note, I was wondering, actually, I'm coming to you, Dr. Wasiche, piggybacking on the conclusion that she just gave us in regard to having that human aspect of solving issues. I just want you to expound more on the health immigrant effect. Specifically, how do you think that HIE would better help service providers here take better care of their clients, especially given that given the fact that some of the policies that are around, or some of the policies that we work with, may not necessarily have the mechanisms to address some of the issues that we have.
Yeah, thanks a lot. Definitely, I can share my opinion. The healthy immigrant effect is heavily researched. There's a lot of literature around it. I can just have my own opinion about it. When we look at client compliance, it has a lot to do with client knowledge. So, having introduced the notion of the healthy immigrant effect, everyone here is already reflecting on what they have changed in their lives and is already formulating what they could do to enhance their life or to maintain a better quality of life. So there are systemic structures which are here, which are not necessarily favorable, like you have just alluded to, because you're in an apartment. What are you going to do about it? But you know, you could just have a footstool that you exercise on every day, even when you cannot go to the gym. You know, there's a lot of talk about push-ups for men. I don't know about that. Six packs. We are always under pressure to have something that we may not necessarily be able to have. But at the end of the day, it is just that awareness which informs compliance. As a service provider, just raising it to the individual. I talk to a lot of people and I say, how is your diet? You realize that the food here, we come from a very vegetarian oriented diet, and we come here and we go to a very meat-based diet. The digestion of that diet is totally different because it is very heavy on protein. And historically, we have dinner at 8 p.m., 9 p.m., and we come here and we now start having a heavy protein diet at 9 p.m., which couldn't be worse. So just having that awareness that having migrated here, a lot of things have changed from our diet to our way of living, to our access to physical activity. We need to have that opportunity to have that dialogue with our clients. And when they understand what is at stake, they have the capacity to make the changes. And because the systemic structures are not going to trickle down to the bottom, there is no way that the city of Toronto is going to be able to pass a policy about physical activity or exercising. We've tried, the city of Toronto has tried to make parking free at community centers and at parks and forestry and recreation, but that is not accessible. Sometimes there's parking fees. So the systemic structures with some of these new immigrant concerns, I don't know if you have any comment in addition, but I think it really, in my opinion, piece is it comes down to individuals' awareness of their inherent capacity to be self-determining, and that based on that, they can change their lifestyle to align. And then these are advocacy piece. There is one of the clinics which used to have so many people just showing up and waiting in line, and it just became overwhelming. So they actually found a solution. They said you could now come by appointment only. And immediately the numbers dropped. So how could you explain that? All of a sudden there was a decrease in access. Because if there was 700 people and now only 40 are coming, where did the 660 go? That's now an accessibility piece. So there is a component for advocacy, because definitely those people have got a need. And when they finally come and find you as the care provider, are you going to have an opportunity to discuss with them what they could change in their life? But again, that's just an opinion piece.
An opinion and a question. But I think what I hear most in that opinion is a recommendation that policy practitioners should be engaging in these conversations so that they can get to know what really happens from immigrant populations that come to this country. So they shouldn't be sitting in their boardrooms and writing policies, but also engaging in conferences like this one to learn more on how immigrants live, not just in Canada, but also how they lived before they came here. And I think that is something that the Canada Blood Service has learned now, because initially they couldn't accept blood from people who are born in the sub-Saharan Africa. And now it seems they have started allowing us to give blood. Initially they weren't allowing us to give blood. And I once questioned, what happens to someone who comes from sub-Saharan Africa who might need blood specifically given by Henry Sully? If you are not taking it from now, and you're insinuating that if someone has had malaria, they can't be giving blood here. I think that's another question of access. And I think they are trying to resolve that, to address that. But thank you so much for that.
You mentioned about food security, that it is an area of interest. A question would be, how come the convenience stores still exist today? even when there is no frills and low blows and what. There is a niche that they serve. Because when you need a sugar cane, you pretty much have to go to a convenience store, probably Caribbean, to be able to get that. So there is a niche of our communities which still depends on that. The food, the blood donation, that's an area of passion for me. We'll chat about it. I was a president for the Sickle Cell Association Board of Directors, and we advocated a lot for blood transfusion because a lot of our clients use and know the Black community is not to donate, but we are glad to hear it's better now. Thank you.
You know, what I would say, John and Henry, is, here in Canada and Ontario, we've made this commitment towards having social services workers and healthcare workers work with more stronger cultural competence lens, right? Like, we've all had training, who hasn't? Like, we've all had that training, right? It's limited. We know that there's limitations because it anchors our lens in our culture and relative to other people's cultures. So we know that's a limitation of cultural competence. But it does speak to some of these issues in terms of continuing to extend that life of the healthy immigrant effect. Because if organizations like ours, because we've almost had to accelerate our ability to respond, be more responsive to this very larger influx of African origin type of clients that we've never seen this many in our shelter, for instance. We've had to really be more responsive to, like, what are their needs? What kind of foods do they prefer? I saw some poor woman once had to put ketchup on something that probably wasn't very tasty to her. And that was like a lesson for us. Like, we have to figure out what it is that these clients prefer to eat versus what we've been traditionally been serving. We have to be more responsible about the kind of recreational and social activities that they prefer over the ones we think that they like. I think this is a responsibility that a lot of agencies need to learn to be more cognizant, more responsive, and show a little bit of that cultural humility so that we can, I think, in our own small way, continue to also further extend that life of the healthy immigrant effect, whether they're immigrants, refugees, or claimants, right? I don't know if you would agree, John, but.
Absolutely. Thank you.
Just, 1 minute.
Yeah, I totally agree. The whole, and this is not necessarily intended for us to look at people from a specific walk of life. It is just to acknowledge that everyone has got something that is unique to them, and that as a service provider, we need to have that intent listening. I keep saying, I like listening to what is not being said, because what is said is very easy to access. But when someone approaches you and does not tell you something, I always go off at a tangent, but just for example, when you look at our countries of origin, there are very few people who have got disability. And you wonder, how come they do not have a disability? Well, disability is undesirable, because as soon as I have a child who has a disability, then when someone wants to marry anyone, they focus on my family and they're like, John's family, they have disabilities. Do not marry from there. So in the interest of the rest of my family, it is my responsibility to hide the child with a disability so that the siblings can get married. So there is no visibility of disability. And when as a care provider, there are all those complexities, and they may not necessarily have to do with where you're coming from or your culture. It is also acknowledging that there are some narratives that are not coming to the table until and unless someone is comfortable with you. So becoming accessible for us as a care provider, listening to those conversations that are not being shared, is what is going to inform a holistic, a comprehensive intervention, and definitely increase the health outcomes.
Thank you so much, John. I want to give an opportunity to the audience to ask questions, but before I give that opportunity, I want to ask my brother here, who's doing an amazing research project. And I'm actually excited that you are comparing populations from Brazil, India, and South Africa. It looks like you are talking about the entire globe, because South Africa brings a little bit of Africans in your research. Indians brings a little bit of Asia into your project. And of course, Brazil brings another aspect of South America into your research. And then you talk about North America, Canada, US. I was just wondering what your thoughts are in regarding to one of the biggest problems, especially when you talk about Canada, and I know you also referenced the UK's health system. I wonder what your thoughts are in regard to the emergency wait times that are accumulating, especially here in Canada, even though we talk about having free health care. So what are your thoughts about the numerous emergency healthcare times versus the seemingly free healthcare in Canada? And what have you found out in regard to how the Canadian healthcare system works versus the US healthcare system? And how has that informed your research in terms of how India, South Africa, and Brazil operate in this realm?
Thank you very much. I'm going to start with the question of the emergency wait times. I've been a victim of that. If all of us have been to St. Michael Hospital downtown, you realize, one, as a newcomer, when you get there, however much have an emergency, the first thing they ask you is a health card. The moment you don't have the health card, the welcoming of that person asking the health staff will change. Then they will just let you be there as they prefer to work on a health card because they will get paid faster than you who's going to be paid by the federal health insurance, which is bad. And sometimes even when you have an ailment and you want to go to hospital, you either have to lie your pain level that is so high, like on the scale of 1 to 10, it's at 10, so they can attend to you so fast, or you have to be picked up by an ambulance into the emergency, then they will work on you. But when you do a walk-in alone, most times they're not going to do that. And I believe this also has to do with the culture and the policies. Recently, I was looking at the health policy integration, especially on mental health for people of African descent. Because as a person of African descent, as an African, when I go to a healthcare provider, a mental health specialist, when I tell them what my problem is, they may not understand the culture aspect where I'm coming from. Because for them, it may be solved by medication or telling you, like, go for a session and that's it. Yet there may be something different from a culture perspective. And we do not have enough mental health specialists, psychiatrists who understand the African mental health, which I've been trying to push. And hopefully that paper, when I publish it, is to encourage governments or provincial or municipal to invest more in integrating the African mental health aspect when they're training healthcare providers, because now our numbers are increasing in Canada. So we need to have that to be addressed. Going back to the point of the healthcare system here and USA. One, healthcare system in Canada is free. USA, it's a different partition. It's outside, you may think it's free, but there are certain partitions which are hidden in it, which people don't welcome most or don't even utilize. Our doctor was talking about here accessibility and utilization. It may be accessible, but people are not utilizing it because they know there's a repercussion or a financial issue coming on. Remember when you had the Obama aid and the way the politics played and they crushed it out, yet it was working to help and promote universal health coverage. In Canada, it's free, but people are not going there. Why? It goes back to the wait times, the number of healthcare staff available. It took me 2 years to get a family doctor. I'm so lucky that I rarely fall sick, apart from having a cold or a cough, you know, those small ailments. But it took me 2 years in Canada to get a family doctor. And every time I try to book, they'll tell you, you know what, the family doctor is not around, you wait for 3-4 months. Imagine if I have a problem and I really want it to be addressed. So There's free healthcare, but people are not utilizing it because the system, the way it was designed. We have very many internationally trained health professionals who could be covering up those gaps. And that is a big policy issue that needs to be worked on. I know the government of Canada is trying now, after realizing that doctor can be having 20 years of surgical experience and have been working in a theater. But when they come here, what can be done instead of telling them to go back for more 7 years to study afresh? But the anatomy has remained the same, whether you're black or white. Okay? So how best can governments do either to have like a bridging program and their experience can be utilized here? So it's different. Both of them will be free, but here the more free one, people are not accessing it or utilizing it because of the perceptions and the way the system is working. Yet in the USA, it is more costly, and I've been seeing people complain like giving birth in the US. The bill you have is almost like an educational bill. So you see like those barriers which are coming in, and in the long run, they infect the qualities of life. Thank you.
Thank you so much again. This is amazing. Who thinks that it's amazing? Oh, I do. I want to give an opportunity to the congregation to ask questions. If you do have a question, I'm going to come to you with a mic. Please be brief, one question at a time.
Thank you so much, moderator. Also want to appreciate the panelists. The conversations were really connecting together. There are a bit of similarities and intersectionalities. I don't have a question, but I just wanted to build up on what Kasaija was saying. Recently, I was part of the Maitri Policy School, and each fellow is supposed to come up with a policy strategy. And my policy strategy is working on credential assessment of internationally educated professionals, pushing to make sure that most of these other different professions, because like you said, government looked at only engineers and doctors, looking at the labor shortages that we are having, like so many. So I'm just saying this is something that we are pushing, and I know it's gonna take a while, but I'm still working on my strategy just to make sure that to get the different allies, make sure that this realizes. The lady from Street Haven, I really appreciate the facts, the fact sheets about. I also work into the shelter system and homelessness. I feel there's a lot of, I won't say discrimination, but per se, most especially when it comes to refugees in terms of accessibility to different services, I feel there's a bit of mismatch, and in terms of providing resources when they come into, as they're integrating into this country. I like the human face, Dr. Kira, that you brought up, the client care. It's really, really important. People should differentiate between science, science and God. These are totally different things. So it's for us to have a multi-sectoral approach in getting to know what is the need. If this is the need, what are the different variabilities that we can use to make sure that we improve onto our health. Thank you so much, moderator.
Thank you so much, Mr. Muzera. It's a pleasure having you.
Can
I'm
we-
going to ask my colleague to.
Excuse me.
I kindly request or suggest that we probably get a second question and then we shall have response because it's our time for lunch. Just
Yes,
about.
so we're going to get 2 more questions from the congregation and
Yes.
then.
Okay, one already
shall
has
wrap
the
up.
microphone.
Good afternoon.
Let's be brief. Thank you.
Yeah, I'm from
Sorry.
the UK, so we came for the conference, and after listening to these discussions, I want to know, back when you say free healthcare, yeah, as immigrants, I was thinking, okay, it's something that UK they pride in, okay, but we realized that most of their medication is centered on paracetamol. I don't know whether does it work here. You know, why is it so? And we would even love to pay rather than, you know, have this free paracetamol stuff. Yeah, yeah.
Okay, thank you very much. Do we have a third question before they respond?
Oh, God.
All right. Oh, there you are. All right. Okay, we will have it.
Yes, I have a question. How can we make Canada less profit driven? Like our healthcare is very much profit driven. I can give you an example. I asked my doctor for a test, but because I'm not sick yet, she won't give me the test. And I suspect that test might show an underlying disease. So what can we do in order to make that? Like that's the first thing you do. You go to a medical doctor, you tell them, you spend like 10 minutes with them, and they will give you a prescription. They're not spending enough time to dig down deep. Whereas if you go to a naturopath, it costs a fortune, but they're giving you like an hour and a half and they're trying to dig, they'll prescribe tests and this and that. And that might uncover the reason why you're exhibiting this. So that's my question.
2 more questions.
I guess
to wrap up.
we needed the Minister of Health of Canada here to answer a few of these.
Okay, I have a question for Dr. John. And the question is, what are the best practices for integrating social work into healthcare setting?
Thank you. We will have your last one, and then the responses will begin.
So my question is about self-care. That's mentioned a lot in social work, and Dr. mentioned it, but really, what are like the most social work organizations? How can you guys provide mental health aids for the workers? Because it's possible, but it's not going to be practiced. We have to look at us, the care providers, how we manage outside of work for single parents. They can't do all these self-care stuff at once. I want you guys to kind of go more into the recommendation of how you can actually practice and not just talk about it, actually practice.
Thank you. Back to you.
Thank you so much, Susan, for taking care of that portion. All right, Dr. Soy, can we start with you?
Sure, I'll try and see if I can touch a little bit on some of the questions that I heard. I'm sorry, the person from the UK, I missed the part of your question, so I didn't quite fully hear it. Yeah. You're given painkillers instead of what they need? Okay, all right. Maybe it's actually related to the second question. So, these are questions that are specific examples, but they're part of a bigger problem, right? Like this is a big system problem that you're raising, and it's how the healthcare system is currently funded, like how it's currently funded, how it currently operates. And I know that, we've turned somehow into a bit of a healthcare system discussion here, but your concerns about like, why do I go to the doctor and he or she only gives me 10 minutes. And then when I ask for a diagnosis, an x-ray or a CT scan, they refuse because maybe it costs too much. The issue is all tied to the issue of austerity and also our funding model, right? This is how currently a lot of our GPs are still funded on a fee-for-service model. That's why they get paid for every 15 minutes. They get paid a certain amount of bucks to see you. And so this fee-for-service model, there is quite a bit of literature out there that shows that it is not the most effective way to providing healthcare, primary healthcare, because it doesn't allow the physician to give you the kind of time you need to do a full-on assessment. The issue of the CT scan and why you didn't get an X-ray or any other MRI scan has to do with concerns about utilization and austerity and whether or not the healthcare will sustain itself if every person who wants a CT scan gets a CT scan, right? And so folks compare ourselves to the US because they're like, oh, we can just go down to the States and we get it like in 5 minutes. But that's a different healthcare system, right? That's not a universal system. People have private insurance. Private insurance has to pay for it. This is all big questions about how we fund and how our healthcare system is modeled, and why someone who goes into a doctor's office and instead of truly dealing with issues around mental health or broader big issues about the individual, you get a painkiller instead, and hence the opioid crisis in Canada, right? But this is all about like, if you're funding your physician 15 minutes for every client, and they gotta they have 100 clients they lined up for the day. That's all the time you're going to get. And hence why even physicians, because it's not their fault, this is a system we created, right? That's why physicians are burned out. That's why many don't want to do family practice anymore, and why we have to go outside and try and recruit and retain talent from other countries, because we can't retain and attract talent inside our own country. We've created like a perfect storm in healthcare system, which is why, when I speak to a lot of healthcare providers and physicians, there's a level of like pessimism and wariness about whether or not the healthcare system is going to do its job, and is it doing its job. Hospitals are doing its job. They're supposed to like give you surgery and you get surgery, but don't expect them to like deal with your entire problems, right? They're not the place for those kind of things, because we created a healthcare system that was dated in the 1950s, and we're dealing with 2024 problems. And hence why we all have gripes, personal gripes about the healthcare system. I'm sure every one of you, and myself included, and everyone up here has a personal story about a gripe about the healthcare system. And this is fundamentally about the healthcare system. In terms of like how healthcare, like social work professionals can be more engaged in the other sectors, this is about outreach. I have to encourage you. When I first came into my agency and other agencies, I literally had to say, like, why do you feel you have to do all this yourself? Go out into the community, make friends, go talk to your other colleagues and in the other agencies like Taibu out there and Evergreen and Yi Hong and all these other agencies are on the back of this promo here. These are our community partners. They want to do as much good as you want to do. They just need to explore. You need to explore those conversations about, oh, this is what I do. That's what you do. Is there a strengths-based approach that you can tackle where if they're really good at, say, caring for older adults and your agency doesn't really have a strong focus on that, you can make referrals and work in partnership with them. So I think there's certain structures and processes we've kind of adopted in our system that we really need to try and break down those silos. And then lastly, the issue of like self-care, like how do we make that happen? I think it's really critical. Like yet again, John, I think it's just the things I've seen in the shelter system I've never seen, right? Like my shelter team will say, we're tough, we can handle it when our clients spit at us and punch us. And I think there's no other healthcare, like there's no other human care services sector where most people would say that's normal. Like that's not normal. Like healthcare workers would just walk out the door if we assume that that was a normal thing that would happen to them, that they would get punched in the face or kicked or get into a fight between two clients. That's just not normal in that sector. But what is not realized is this cumulative stress for these social services workers, right? Over time, it plays on them. And unfortunately, sometimes it plays out in undesired behavior where they act disrespectfully to their colleagues, they act disrespectfully to management, they're unhappy in their workplace because of this kind of stress that they're engaging in the workplace. I think as employers, as agencies, we have a responsibility to invest in things like mental health and trauma. And, as a worker, you should demand it. Tell your union you want this. Tell your employer you want it. Because if you tell us, we will want to give it to you because we want you healthy. We truly do.
Thank you so much.
Sorry, I'm so sorry.
Thank you so much, Dr. Achen. There were some questions for you. If you want to respond, you can respond now.
There was a question which was asking about best practice for integrating social work in healthcare or healthcare in social work. I don't even know which order it was, but since we are talking about social work in healthcare, I guess it doesn't really matter. That is a complex question because like we had spoken earlier on, it is really for individuals, right? Because at the end of the day, and it was also related to the component where we're saying, how are we expected to do this when we have our competing challenges in life? And that is the complexity that we are dealing with. Making ends meet in this country is so, so hard. There is a need for policy changes, in a way that acknowledges and accommodates our lifestyle. Up to date, I do not understand why we have the shift 7 to 3, 3 to 11, and 11 to 7. Because the people who work the shifts 11 to 7 have to wake the residents in the long-term care homes.
and dress them only for the residents to stay home? Why do we still wake people at that time? And by the same token, the staff are also moving at really odd hours. At what point are you going to take your child to school or pick them up? So just that schedule is a pain to the patient, is a pain to the client, is a pain to the administrators of the long-term care home because they are chasing around the staff. You did not change the diaper for John on bed 17. Well, for me to do that, I would have to wake him up at 4 a.m. How fair is that too? So there are some of these structures which are really interconnected in a way that makes the life of the care provider so complicated. And so when we even start thinking about self-care in such a structure, it becomes so hard to figure out when can I take care of my child? Because my shift is from 3 until 11. Do I pick my child from the bus stop? Do I leave them in the house alone? There are so many complexities. But when it comes to self-care, it can really be a small thing like taking a walk. We were driving with my wife. We commute every morning. And I was telling her, today I'm really not going to be chatting with you because I'm trying to focus on what I'm going to be talking about. So then you realize that coming to this workshop took away my opportunity to chat with my wife while we were commuting. So you find that our jobs sometimes interfere with our ability to socialize and sometimes our socialize. So it's really interconnected, but it is partly the systemic structures and how they are really set up that they do not accommodate. We all live on a budget. I'm not a gym person and I don't know how people afford it. But if someone would like to go for a walk after our session today, I'm game.
Thank you so much. Thank you so much, Dr. Sichi. Joseph, talk about the issue of efficiency. Before we wrap up.
Are we good? I don't think you're good because it's already lunchtime and I'm suggesting, if it is okay, let us serve, come and sit, and maybe we can have other questions responded to as we eat. How about that? Because it's the mouth that eats, the ears will be busy doing their job. Because we wouldn't want to rush them. We still need to hear so much good that they have to share. What do you think? And there are several sessions for questions we still have. So at this point in time, I think we need food. In the word health, there is EAT. We need to eat. Yes, don't you think so, Dr. Sui? Lovely. So we can be able to have this after we have served. How about that? Okay, clap me once if you agree with me. Only once. Clap me once. Cha. Again. Cha. Oh, even the clapping is a little bit. Okay, let's go and serve quite quickly and then we come back. And I have a surprise for you. Yeah, the vision bearer has a surprise. So we have an afternoon session that is going to be very exciting. And at the same time, tomorrow we are here the whole day. And trust me, last for best. So make sure that you're here tomorrow. So let's go serve. Thank you.
She's leaving, but she's still there until fall, right? Yeah, I want to connect with her before she leaves.
amaso yanjye ni kubareba urukundo w'amayero bakwifuza kandi sinicuza ikome mo bebe satisfy you for life. Ukuteye nukusabirangaragura shesije mafuze kwa amaso yanjye ni kubareba urukundo.
And we have this area. This is where we're going to have our lunch from. And the drinks are there. So just feel free to go there. Thank you. We are having our lunch for 15 minutes. I think that 15 minutes is good enough, okay? 15 minutes.
juice. Take a sip of my juice. Take a sip, babe, don't you stop. Pour me Henny, you do scotch.
Beats kicking, bouncing with it. Me, my guys chilling. Hold on a minute, cause I see your waist. Really up the stage. Really wanna touch me, I really wanna play it. I wanna know who are you? Don't mean to. What are you? Sorry, excuse me. Who are you? Don't mean to trouble you, yeah. Tell me she feeling me. She tell me she want follow me to the corner. My friends, them are calling me. I tell them hold on, she's gone. See, girl, I wanna get to know your body, your body. You know you gotta go where you stay. Your body making me feel this way. Oh my God, need us. Don't wanna reach to someone else. I know you gotta go where you stay. Your body making me feel this way. Oh my God, need us. Don't wanna reach to someone else. I let her know that sleep back girl. You tease me. She telling me, oh me, squeeze me. You turn around, don't be greedy. I don't believe it's big dirty girl from Jamaica. Is it because I'm smiling? Oh yeah, baby, you want me? Oh, yeah.
Night running around in my head, and you do it without breaking a sweat. Got the kind of love you know I can't get, you know I can't get, you know I can't. All my emotions, you know. You take the lead and I'ma follow where you go. And all of the power you hold, yeah. You take it away, I've got no love. So bring it back, bring it back, bring it back. Cause day and night running round in my head, and you do it without breaking a sweat. Got the kind of love you know I can't get from anybody else, yeah. Come on over, help me mess up this bed. Don't act like you don't know what I meant. Make the kind of love you know we can't get from anybody else, yeah. Could say I don't love you, but I be a liar. I know that you know that you're my only desire. I could say that I don't care, but I be a liar. Even when I'm cold, it's used to set me on fire. Day and night running around in my head, and you do it without breaking a sweat. Got the kind of love you know I can't get, you know I can't get, you know I can't get.
Yeah, wow, I'm in danger. Bring your body, make us spend my paper. Tell you things that I cannot say loud. Got me thinking about it right now. Is it the body or is it the face? That got me feeling like I wanna stay. I'm trying to hold you like a conversation. Don't you ever try to get away? So many reasons where I want it for you, my love. Now you want all the time with my love. Oh. See all the little good things you do, they make me know. This distance is taking a hold on me for sure. Baby, come closer. Oh my heart, you make me dance. Oh, and I want to make you love. Oh, no, I feel like making you love. Oh, no. Oh my heart, you make me dance. Oh, no, and I want to make you love. Oh, no, I feel like making you love. Come on, pull over. Wait for you all the time. All the time, all the time. What you got make me need to work all the time. Dental on my mind and all over my skin. How have you been? Dental on my mind, setting fire to my skin like you smoke to Cuban. See me on TV while we had it happen, and you know we rockin' the book, no stepping. I'll pull you closer when you hit the spot, and boy, you know I'll never fake for no one. No, what you see is what you get. So pull over, come closer, make you forget you had it inside. Feel like water with inside coconut. See Papa if you give me stamina. Wait for you so the same time come up. Me and you at the same time. I never want to leave, mama. So dance with me, mama. I pull up on your beach, mama. It's time to swim, mama. Baby girl, make you know the light. Oh,
Make it tell your friends, see they feel this guy. Don't even waste time. Cause now me you go follow till the day we die. But meanwhile, I can't wait to make your face just smile. It's not a lie. You set my soul on fire. So many girls that pass through, none of the girls find pass you. So many things you've been through. Life will not be the same again. Wouldn't be the same again. Will never be the same again. Will never be the same again. Never be the same again. Don't mind them, change the light to you. The talk say me I'm too bad for you. Don't mind them, mind the light to you. The talk say my heart a glass, someone don't break it, oh, break it, oh, break it, oh. Different time, wait it, oh. When the man a take it, oh. On your ways, we be ready, oh, rotate it. Maybe me and ready, oh, wait it. On your ways, rotate it, oh.
You want me to go? I feel more than I want. So don't go too fast. Tell me something I'm wrong. From my face to your mind. 20 more than the time. Don't go too fast. Told you time after time. Shake it, I'm ready. Shake it, I'm ready. Fake it till you make it. Shake it, I'm ready. Shake it, I'm ready. Shake it, I'm ready. Fake it till you make it. Shake it, I'm ready. Call me for talking time. What we want. Call me for talking time. What we want. Call me for talking time. What we want. Call me for talking time. Shawty, I can't be caught in no love. What the fuck is the room full of drugs? You can take what you want. Throw me inside of a cup with your button and boom when you bust it. A splash when you fuck it. Water and mixed with the substance. I keep shit from belly, I slide it. Surely, baby, for shoes to sex them. On plus shit for block for breakfast.
Lights, camera, action. Ready for the interaction. No, she out here without fear. Say she not get it, she will pull tantrum. Foreign girl to London. I walk and go so pam pam. JT a play, but she turn it up. Cause she wanna listen to she love Batman. Your body have you talk about it. But the rum and then go drink out it. You good buff, girl, you have a good girl. Your body have you talk about it. But the rum and then go drink out it. You good buff, girl, you have a good girl. You bust the style and go low. You love the wine and go low. Take your time, it's a grow. Go. You bust the style and go low. You love the wine and go low. Take your time, it's a grow. Go. Good girl, look at you well buff. Do me a favor, align for the fuck. Grip me with your pretty muscle front. Tipsy from she drink like a rum. Get your pussy good and your pussy clump. Say she honey and one off thump. Say she in love with my verse and my song. So me tell her take it and don't run. If you clean, girl, walk and say fade. From she side, but me know she ready. And your blouse well cute and pretty. If you clean, girl, walk and say fade. From she side, but me know she ready. And your blouse well cute and pretty. You bust the style and go low. You love the wine and go low. Take your time, it's a grow. Go. You bust the style and go low. You love the wine and go low. Take your time, it's a grow. Go.
Rolling on your wheel now. I'm drinking Hennessy now. I hope you see now. Say you don't bust my eyeglass. You don't scatter my plans. See my eye, I don't cross. You put me for ambulance. See why you make me bitch. See why you make me bitch. See why you did to me. God save me, please.
always had it on a necklace. She said, new phone, who this? As soon as I texted, then I saw a pretty little face standing right by the exit. I said, it's funny that you here, cause I know this really ain't your thing. She said, you got that right, and I car will arrive in 15. She said, it's 12:35, and she still got work in the morning. I ain't trying to kill the vibe, you can see it in my face, I'm torn. Yeah, but wait, just like magic, they playing our song from way back when we fell in love. She put down her jacket and gave me her phone, said I can't stay, but just hold up. Moving through the crowd, almost dropped my drink, girl, we in LA, that shit ain't cheap. She said you ain't changed one bit, put my hands on her hips and said just focus on me. Her body like Calypso, yeah, she throwing that back, come on, leave with my fist on the fist. I love it when you get low, I slap my hand down your back on your thighs when you get those. Once when she move her hips up, already knew you were bad, but I act like I didn't know. I know too, I know that's good call. There's a party in my bed, can I send you the info? Her body like Calypso, yeah. Come on, with my fist. I love it when you get low. Oh yeah, when you get low. Once when she move her hips up, so up in my bed. I know too, I know that's good call. There's a party in my bed, can I send you the info? Can I send you? We go rendezvous now.
Is it a fiction? A habit or just an addiction? Cause I can't get enough of you. Baby, listen, cause I'ma need more than a doctor's prescription for me to get over you. Usually I know where this thing could go, but you gotta be quick about it. If you take control, I could let you know. No, I can't live without it. I've been drinking more alcohol for the past 5 days. Did you check on me? Or did you look for me? I walked in the room, eyes are red, and I don't smoke banga. Did you check on me? Did you check on me? Or did you notice me?
In bed, but my mind stay wandering, overthinking, but I'd rather be sleeping. Grab a drink, I need escape now. 247, I be in this state now. But I can no longer depend on it. I become my own sanity. I don't question my own sanity. Waiting to be safe, but I'd rather be alone than to have fake friends. Check on me. Well, let them get to me. I'm just tired, not trying to be lazy, cause I got a lot that I've been dealing with. I know you understand, I know you
I've been drinking more alcohol for the past 5 days. Did you check on me? Or did you look for me? I walked in the room, eyes are red, and I don't smoke banga. Did you check on me? Did you check on me? Or did you notice me? I've been drinking more alcohol for the past 5 days. Did you check on me? Or did you look for me? I walked in the room, eyes are red, and I don't smoke banga. Did you check on me? Did you check on me? Or did you notice me?
Yeah, you broke me and took your time with it. Yeah, you gave me all these memories that I regret. All I can do is congratulate you. Ruined me for everybody. Yeah, you ruined me for everybody. Wake up in the morning, a different girl be on my line. Constantly be calling, every day I still decline. See, this exactly what you did. You ruined me for everybody. You ruined me for everybody. Oh, bye-bye. Good riddance for the last time. So you can try, maybe get it right next time. Different time, but maybe you can be mine. Ruin me for everybody. You ruin me for everybody. Oh.
I don't want to be confused. Free fall, pull up parachute. You play, let your arrow shoot. Oh no, I'm back into you. Punching with my heart. I don't want the risk. I don't want to be caught up. Don't want to commit. If you're jumping with my heart, please understand the risk. Please just try be cautious before we dive right in. I said that is with you. If you wish, if you want to. Take that risk with you. If you wish, if you want to.
Just stand there feeling me. This my king, but the way I see. Still my kiss, cause I don't bite. This my tea for the whole night. So my body too bad, so I don't like her. Giving me sign that I don't like her. I'm just saying I don't mind. This my tea for my whole life. Talk, but talk is cheap. We don't need favor from no one but God, plus I got me. Talking all the time. What else have you done for your niggas out the mud or your people's outside? Too much energy for you wasted. Too much time. Too many enemies from friendship. Flooding my lines up. You're fucking up my mental space, man. On my high. Too much energy for you wasted. On business, not mine. All the diamonds in the world don't push me. Every blessing's got a fall, so I don't sleep. I want to be alone. I want you just leave me alone. I want to be alone. Why don't you just leave me alone? Love you like a gangster. Praying on my prayers till they answer. On my knees, and they still bleeding free. And enemies say they want to tell me to their hands. Asking God, please. Asking God, please. Why me, why me? Why me?
We not go far, we a go, we go, you go know. All of the blessings fall on my yard. Blessings stay for my yard. And like a that, you go be, you go see, you go feel because the blessings fall on my yard. Blessings fall on my yard. That's why I say fire go all. I don't want to reason bad things no more. I don't want to go back to where I did before. Make nobody stress me, not disturb me, cha. I sip my alcohol. I don't want to reason bad things no more. I don't want to go back to where I did before. Make nobody stress me, not disturb me, cha.
Now which kind life way I never see. I carry God so I fear nothing. Steady increase in the commas. Original no be parody. You know fit clear for your memory. Whether now winter or summer. I did Papa just now. Living life. See my fire burning bright within the inside me.
only way they might see them never know I color. To the move fine, check and balance. Everything inside my mind daily. Trust me, you can't fool me. Energy don't got logo. Go a friendly and conscious. I'm allergic to so. I'm not ready for confusion. They're telling me make I show love. Stability on gonna. Everything a connection. I'm not ready for confusion.
Man, get united till I fade out. If the vibe no pure on my way out. Ula balu, anytime we step out. The men them outside, we know they house. No they look us, we know they house. No they see the mullah, we don't spray out. Thank God, said the maga don't pay out. Okay, oh, see, I'm ahead of them, I see what you. I'm a fucking baller, got only me. No man fit talk shit to me. Me know me, you go collect, oh. See, I'm on a me daily, I see what you. I'm a fucking baller, got only me. No man fit talk shit to me. Me know me, you go collect, oh. Cheers to my friends and click. When I call them, I all pulling up. We strapped up with the guns and the swords and things. Bring hell to anybody who try to test me. I'm your dad, I'm your uncle, I'm your popsy. I be old man, no go, they call me Gen Z. Brother C, steady giving them top, multi love far. They can never near me. I smell lover, just go. My own boy, don't show. I'm on my polo white, my face show. Sweet boy for life, you don't know. You're serious, babe, they worry my phone. You done this up for back, you don't know. Every day we dey run among tour. Supposed to know the thing go. Man, get united till I fade out. If the vibe no pure on my way out. Ula balu, anytime we step out. The men them outside, we know their house. No they look us, we know their house. No they see the mullah, we don't spray out. Thank God, said the maga don't pay out. Oh,
maybe not the way that you talk and the things that you say, but they make I feel upright. And I catch your vibe anytime that I look in your face. Tell me why you look so fine. Baby girl, I see you. Wanna ride you like a bicycle. And you they blow my mind from a mile or two. And I no go lie, you light up my day. And when she tell me my love, is you love, baby. She know when the Gucci bag or the Fendi. Yeah, she give me butterflies in my belly. Good love. And when she tell me my love, is you love, baby. She know when the Gucci bag or the Fendi. Yeah, she give me butterflies in my belly. Good love. And when she tell me my love, is you love, baby. If I was shining, baby, she gon' stay. Yeah, she give me butterflies in my belly. Good love. Your love is crazy, girl, your love is crazy. You amaze me, girl, you amaze me. All I know, them only really want to play me. But when me there with you, I realize your love is crazy. You amaze me, girl, you amaze me. All I know, them only really want to play me. But when me there with you, I realize
my love, don't go, baby, slow down. No, do me conio. Oh. Me, I no be JJC. You no go see me finish it. Steadily, your time is ticking. So much sensitivity. Why are you so defensive? Just cause we have differences, I know. On a different frequency. Not by force to get distance. If you don't, then just leave me alone. Why you wanna siphon me? Controlling, oh you wanna control. But me I no be JJC. You no go see me finish it. Steadily your time is ticking. Why you wanna siphon me? Controlling, oh you wanna control. But me I no be JJC. You no go see me finish it. Steadily your time is ticking. So much sensitivity. Why are you so defensive?
Just cause we have differences, I know. On a different frequency, not by force to get distance. If you don't, then just leave me alone.
That sign. Kalash, kilish, kalash. Da 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 da. Say you're bad from which part? Tell a pussy we no gun dip dog. Like Chinese war, so the clip tall. Show it up and make you fall from your disc dog. You know want none of this cause, man a big dog. I saw you disappear as if you never did ban. Me no walk up a kilo, me no just a sing song. With the people your mother tell you keep fam. Z-Tech full of bam like Islam. And if you with me kike, me know the enemy. Them a pray, and me know they not sorry for me. People are ball and a skin, cause we bad than we mean. Bloody crime scene calamity. I saw we shoot out, we and figure Canada G. Make them have a experience, no gravity. And tell a pussy we no laugh, we no take talk. Violate people are dead dog. No shoulda keep in your bed cause the Talibans them a make quack. We no laugh, we no take talk. Badness is how we end us. We no show people feeling up in a red grass. Yo, Taliban's like them near reassure guns. Make you no sleep at your yard in a 4 months. And so we make people a mourn out. Like y'all get fucked down a whole house. Laugh bars full of care that me sure about. And if you see me travel with a 9X, and no politician with me I go vote out. 4 kilo, 4 seat and 4 rounds. Remember me born Kingston. The love party forget love drink rum. AK shit like a Jada Kingdom. Everything I get fucked like strip club. So me stay sharp. When I play that, do we get it one time in the same spot? Like iPhone, where your ear drop. I mean I give a fuck if I not be a pop.
My life is a different story. It's a movie written by God. My heart on my sleeve, so baby. My wrist won't keep enough blood. My dice got heavily rolling. My six got a perfect landing. My life is a different story. It's a movie written by my life, chaka chaka. My life, ururu. I did thank God for mercy, for don't takuru. My life, chaka chaka, oh. My life, ururu. I did thank God for mercy, for don't takuru. My life, chaka chaka. My life, ururu. I did thank God for mercy, for don't takuru. My life, chaka chaka, oh. My life, ururu. I did thank God for mercy, for don't takuru. Kuru, 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 kuru. Kukuruku of my money daddy. My cash pass ready done. Kuru, 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 kuru. She know where the struggle don't reach. She can't start to do for her fans all. This pain in my head, 365 days. So Jama no look sideways. So Jama no look my age. Best way. So Jama no green my grades. I mean what I write and lace. So Jama no rehydrate. My life is a different story. It's a movie written by God. My heart on my sleeve, so baby. My wrist won't keep enough.
It's been a hell of a ride, but every single moment you were there by my side. Whenever I'm broken, you make me feel whole. Whenever I'm lonely, you're there for my soul. Wherever you are, girl, that's where I call my own. Whenever you doubt it, I'll be letting you know. Oh, girl, I want to be dancing with you forever. You see through the storm and take me as I am. Baby, it's magic anytime that we're together. I make I just love you and hold you for my hand. Hold you for my hand, hold you for my hand, hold you for my hand.
Over and over again, yeah, my love is burning, babe. Feels like time is frozen and tonight is for us. We're alone again, every moment's golden, yeah. Feelings I've been holding in, it must be love.
Whenever I'm broken, never run lonely. You're there for my soul. Wherever you are, girl, that's where I call my own. Whenever you doubt it, I'll be letting you know. Oh, girl, I want you to dance with you forever. You see through the storm and just take me as I am. Baby, it's magic anytime that we're together. I make her just love you and hold you for my hand.
I need your loving, so fresh, so clean. Love me in and out, unfailingly. And I'll be down now. Anytime you call me, I'll be down. I'll be down. Because I love and I love and I love and I love you only. Because I need and I need and I need and I need you more. Yeah, you know I run and I run and I run and I run. Fly, we can fly in the sky in the night. Hold me in your arms and your love and your light. I'm on your wave right now. I'm on your wave right now. Yeah. I'm on your vibe now. You got me on your side now. Yeah, I'm on your wave right now. Yeah.
Queen to the motherland. On the other hand.
She said, come if you wanna. I say, I know myself, I'm gonna wanna activate undercover. So let me know. She say, one name big go. Activate if you wanna. Let her know it's not the normal size. This kind thing don't make your ship capsize. So let me know if you wanna ride. She call me brother, I call her sister too. Mama so fine, she got like 6 tattoos. If she was a city, she be Timbuktu. My holy ground where me around to brother. I call her sister too. Mama so fine, she got like 6 tattoos. If she was a city, she be Timbuktu. My holy ground where me around to. My holy ground, baby,
I said, come if you wanna. Got to drink the marijuana. Let me know whenever you decide. Let me know you put them bitches to the side, yeah. It's you on my mind. It's you all the time. You came just in time. You gave me my spit on the mic, something you could bump to. Get nasty for you every time you come through. Finish line who you run to. Keep you grounded, I wholly ground you. Hey yo, I'm giving medals, I gotta give you the G. I'm bouncing all on the D, I just had to give you the V. Here blowing all in the wind while we cruising Penelope. Nigeria to the world and fuck you to my enemies.
All of the things I'm talking about, yeah. Try what you not do if you're not the fair. Mama did they tell me to disappear, yeah. So come my head, no, cause I don't pray, my man, I don't pray. Come on, man, I can't stay for one place, because my place.
Oh, mommy, don't leave me, go Dubai. You're the one I want. Can do this on my own. Oh no, yeah. Are you everything you like? Roses and diamonds. You're the one I want. Oh nah nah, yeah. Girl, I need you to decide if that make them jealous of you. Now you I want got up on you. Hey. And I need you to be mine if that make them jealous of you. Now you I go color for you. Diana, Diana, please don't leave Diana. Diana, she let me go so far, Bena. I beg her, please don't leave Diana. Diana, oh yeah, oh yeah, oh yeah, oh yeah. the Diana. Sick in love, highs and lows, nothing to cure it. I losing faith, sinking out, swim for shore, ready to prove it, my love, baby. I've been shipwrecked, stole my heart of gold, my soul stuck healing here. Will you find me before I'm skull and bones? SOS fire, I'm at the time I am. No one looks like you, no one walks that way. And I said, ooh, buddy, what's your name? If I lose, I lose, I'll get you someday. SOS fire, SOS fire, yeah. Solo. You know I've been writing solo. Before my tour get promo. Now they call me a dollar. May nobody call me a dollar. I get no $1 with feet passes. When I do wear my dollar. When I don't get tea cup. See I panic for my cup. Don't need so many things you done. Me I don't need fight since when I never thought you should see me stop. Please stop it. Me I know the year what you are. Stop it. Now stop on gun. Stop it. Me I know people you I don't know. Stop it. Stop it. Me I know the year what you are. Stop it. Me I know people you I don't know. Stop on gun. Stop it. Don't know. Look, I carry them, go where them no know. Look, I give them this step like Bobo. Originality, no be Bobo. I'm a yummy, won't you go? At the fight of the wars on the Lolo. We go low, see me the corner solo. It be like, say, yeah, I don't go low. Drivers in a lie, say, na ego. Oh, and let them in my day solo. Bukata me a tipo. For my family, I be stubborn. Enter their body like robots.
My dog is on probation. Another 5 years. Bring girls to his location. No time, no. Send me the location. This year about vacation. Flight catching, train taking. Soon as my nigga off probation. Your boyfriend's on a waiting thing, looking for one wish on a Ray J thing. I prayed that girl, outrageous thing, but she can't see cause I got shades and thing. Bare girls wanna throw shade and thing, no shade, what shade is your foundation in? Darkest grey, the shade I'm in. 49 more if your babes wants in. I had me a famous thing, hoes and things, gains and things. My house party, a babe station. Girls wanna chase, it's a status thing. Send me the location. And I'll be right there. Make her come check you out, babe. No time, no. My dog is on probation. Another 5 years. We bring girls to his location. No time, no. Look. Playboy, I don't need a cardi. I'm captain, I lead the army. Bad ratio, I leave the party. Free Somalis, creeping on me. Your ex-wavy, we tsunami. Girl from India, sweet as Nani. Head so good now, speak Gujarati. You pardon me, I'm laughing again. I assisted, man, passed my friend. Money like the alphabet. If you wanna see P's, gotta pass on the ends. Came a long way from a park in a Benz to an 18 plate man's park in a Benz. Far from the rest, but I'm far from my best. Life is a lesson, I'm passing a test. Yes, everything blessed. I don't want drama and I don't want stress. My girl got finesse, Caribbean flex. Body and chest, take body and chest. Thank God more, I brought with less. Just to the right, raps to the left. Arge in the middle, got seed to the death. Batch full of dogs with the 16s vex.
Baby, follow my command, like zombie. Go down on me, oh, with your coca body. Follow my command, like zombie. Go down on me, oh, with your coca body. Cause this your milky for front enough for me. Hold on for me, I no go to me corny. And if you're milky na fighty, I saw me to look. Gelato honey, oh baby, some more
Baby, kona, waka waka when you enter Malika. Baby, kona, will you give me sugar, wala. Macho Mona Lisa, 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 Macho Mona Lisa.
Mona Lisa, I go sweep you off your feet. What up, She said, make some time for me, See, for this let me and you tap like hush puppy. We walking next step, please show them your face. Baby, hope you know you like to my day. Girl, you know you're all that I need. Give me your love, you can't run away. I can't deny. One bag of man, them one come try. But my love just takes you out. All them I talk about you and I. Nobody listen to them loud. I get butterflies when I see ya. Oh yeah. If I'm in love, it's for a reason. Oh yeah.
Don't this up, I'm wanting you. Got a lot of options, wishing they were you. Don't be the guy that walked away. That's a mistake, you shouldn't let it go. Go easy, don't act like you don't need me now. You're so busy, but don't act like you don't see me now. Don't be greedy and jump on the next thing you see now. You see now. Don't you leave me for the girl next door. Don't you leave me for the girl next door. Girl next door, girl next door, girl next door. Don't you leave me for the girl next door.
Goodbye for that girl you see outside. You know her loving ain't gonna be better than mine. And you know I won't waste no time. I can't have another you by now. You know it's you I love, so you better just take your time. I'm just saying, oh busy, don't act like you don't need me now. You're so busy, but don't act like you don't see me now. Don't be greedy and jump on the next thing you see now. You see now.
Don't you leave me for the girl next door. Don't you leave me for the girl next door. Girl next door, girl next door, girl next door, girl next door, girl next door. Don't you leave me for the girl next door. Girl next door, girl next door, girl next door, girl next door, girl next door. Don't you leave me for the girl next door.
Yeah, I'm okay. Wait, I get it. Yeah.
It is a brilliant afternoon, I suppose, and I know that whoever still had space went for second helping. It's very healthy to have more food, okay? Especially salads, vegetables, you know, it just makes you healthier. Are we together? Can you say hello to your friend, to your neighbor? Tell them, how are you feeling right now? How is everything? It's very important to keep checking our mental capacity when it comes to emotions. Make sure everybody feels emotionally upright to even sit next to you. We want the positive energies, not the negative energies. Are we together? And I also kind of request the people who are so much at the back to come closer. We are giving out some dollars at the front, so you don't want to miss on the dollars. Just come at the front. Yeah? There's some dollars. Oh, yeah, dollars. I'm talking about dollars here. Please come up front. Thank you. I'll count to 1. I'll start with 10, 9, 8. Please come at the front. Please. Thank you very much. You're very respectful. Thank you. As you can see, my hand goes beyond, so you probably are safer. Let's come closer, please, I beg you. We wouldn't want to see so many empty seats. Okay. Okay, there's something to excite us. Just a few minutes before we begin our afternoon session. Before I bring in a surprise, kindly stand up for a while. It's starting to be cold in here. I hope you're okay. There's a particular song that our parents used to enjoy, okay? And that's the song that we are going to listen to, and you can dance so that that food can go down the feet. How about that, okay? So when the song starts, you will all connect to that song in a particular way. Either your parent, auntie, mama, or you yourself, you enjoyed that particular song, okay? Time for a little bit of therapy, round about now. Do you remember that song? Come on, give me some dancing. Come on. Shake the head, shake the leg, shake the hands. Some therapy, come on. I remember those years we used to sing, our parents used to dance. Feeling hot, hot, hot. Feeling hot, hot. It is time to become younger. 15 minutes younger. Who doesn't want to be younger? Come on. Ole, 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 ole. Come on, clap for me if you wish. Ole, ole. Feeling hot, hot, hot. Are you feeling hot, hot, or you feeling cold, cold, cold? Come on. Feeling more what? More lovely? More healthier? Feeling hotter? Come on. Come on. Show me some love there. Maybe I need to move a little bit in now. Feeling hot, hot, hot. Come on. Cha, 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 cha. Chansa, chansa, chansa. I need positive vibes right about now.
I don't want to see anybody not smiling. Hot, hot, hot. I'm feeling satisfied. Cappuccino. Lovely. Feeling mama. Thank you, DJ. You've done great. How are you feeling right about now? For those who have debts, the debts are paid. Don't you feel like that? And you know, it starts with a feeling, it starts with a thought, and before you know it, you're able to think brilliantly on where to get the money to pay the debts. Not so? Yeah. A sick mind can never think of something interesting. Okay. So our session is going to begin with another very important therapeutic technique that many of us don't really take serious. Music, dance, and drama are those things that are very therapeutic. I'm a clinical psychologist, in case you didn't know, with an education background. So I know what it means to be mentally low. And many times I try to carry myself up with music, dance, and drama. So we have a legend musician, Ugandan origin. A legend musician from Uganda. And I remember that we used to have a Frigo band, which many of you have enjoyed for so many years, but we also used to have the Big Five band. And it used to have one little girl and one female only, and that was Julie Sesanga. For those who remember, most of you probably were still very young, but yes, she used to be the only lady, the only female, and she was quite young then, but of course now, still young in a nice way. So she's going to entertain us. And I want you to feel good, even when you don't understand the words that she's going to sing. The first song is going to talk about the girl child, yeah? Grooming the girl child and how to help them to socially survive irrespective of the challenges that are in society. That will be the first song. And it's a new song, so you're going to be the very first people to see it. Isn't that amazing? And then the other song is talking about love. Well, she will tell us more. She has a couple of them. So she's going to tell us exactly what the songs are. And feeling hot, hot, hot. I feel the song in my head. Feeling mama, mama. Didi. Feeling ha, ha, ha. Didi, 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 didi. I can even piano it, you know? Okay. Yeah, we are getting ready with the songs. So far, so good. Can you tell me what you have learned from the first session that we just had as she prepares her songs shortly with DJ? What have you benefited from this wonderful conference? Do we have anybody that has something to say that you probably have benefited? 5 minutes is a lot of time, but we will wait. We have no option. Anybody has something to say? What have you learned? Okay. Can you market your organization at least? You probably have nothing to say, but you can tell us your name, tell us your organization and what you do in just a second. We need what we call the elevator marketing. Yes, please help me. The pretty lady has something to say. Yeah, because it's time to network while we wait for that music. And our next speaker is organizing themselves to come.
Thank you. Maybe I'll stand up.
Yes, no worries. Stand up.
Hi, everyone. My name is
Hello.
Rachel. I am from Edmonton, Salvation Army, and I'm a social worker there. I'm happy to join you guys here. I just want you guys to know that you don't have to stay in Ontario, okay? You can come to us. There's lots of jobs in Edmonton. My organization right now, we have 3 different programs. I'm the social worker for the supported housing program. We have stabilization, and then we also have transition It's all has to do with mental health and addiction. So, there's a lot of opportunities outside of Ontario. So I hope you guys can think about it. And, because I'm from Ontario too. I did my education here, but life is better over there.
Madam Suzanne, we're at these ends right now.
Please.
Good afternoon. My name is Millie Nalwanga. I trained as a social worker from Toronto Metropolitan University years ago. My employer is Toronto Community Housing. I do work as a community services coordinator, access and support for vulnerable tenants. So pretty much I do support people to make sure that they don't lose their housing. And I feel that this conference, I have learned how to support, how to coordinate, and I've learned a lot, and thank you so much for organizing.
Wonderful, thank you. We are going to continue with that session a little bit later. We are going to have one song first, and it should be the song for the girl child. And thereafter, we will have another song later. Are we together? Hallelujah. Lovely.
It's nice being with you this afternoon. My name is Julia Sesanga. I am a performing and visual artist. I'm a teacher by profession. I'm a music scholar. And it's nice being with you. I like using music as a therapy. And I think it's imperative in the science to always have therapy because we combat very many things. Thank you very much. This is the first time I'm singing this song. I just released it last year, end of last year. It's called Sekanyoria, about a long bird, a bird with a long neck in Uganda. Agenda nakuwana wana nawe nobegerera nakuwa kano nakali ngatasibye namu buli kizibu ky'omugamba akola neyemalayo nomatira nti teri kabi ekiva ewuwe ndaba kulimba nakutuga ngamba gwe kibuggulu weefudde kiggala maaso ogakutte mu ngalo lwaki tolaba wala nga Sekanyoli oyo bwe walampa amaka g'oyonoona watyanga gamaamawo oyakulimba weekana n'abaana be ekyakuleka newokaaba amaziga laba kutaddemu teryakutunulamu n'abaana bakukyawa wadoobya maama waabwe oyakulimba weekana n'abaana be ekyakuleka nebwokaaba amaziga laba kuzaddemu teryakutunulamu n'abaana bakukyawa wadoobya maama waabwe bannange njagala mube nga Sekanyoli oyo agenda mpola n'alaba n'afuna ekyokulya temufuuka biwuggulu amaaso n'obwongo mubikozesenga balabula ebirungi bya bugumiikiriza balabula ebirungi bya bugumiikiriza nze mbalabula bya bugumiikiriza balabula ebirungi bya bugumiikiriza Tekigaana kuzinamu. The rumba style. Never. Thank you. Thank you so much. That was Sekanyoria talking about the girl child trying to advise the girls to avoid dating sugar daddies. Thank you.
And sugar daddies are basically cross-generational relationships. A 15-year-old girl getting a 50-year-old, someone old enough to be your father or grandfather. These things happen in our communities, okay? The social workers can bear witness to that. At this point in time, we are going to have a silver sponsor. We have very many sponsors and people that have donated towards this wonderful, amazing conference that so far so good since I came to Canada. I think it's my #1 extremely beneficial and greatly organized. A big hand clap, I thought, would come after that. For the vision bearers, thank you. You have really done so much good. Bringing a job fair on the outside and then a brilliantly, fully packed, knowledgeable, wonderful speakers in here. We have people that have gone an extra mile in making sure that this comes to this level. I have met their stall and trust me, it's amazing. So I want to thank you, Shintha Alam, for leading a delegation of Dixon Hall here. These are people that get us jobs in Toronto and in Canada, world over. We already have her brief here, so you can be able to go and revisit, but let us get her address because she's one of actually the silver sponsor for this amazing conference. Thank you so much. One clap for her. One, just one. Cha. Let's do 1, 2, 3. 1, 2, 3. Brilliant. Thank you.
Yeah. Hello. Do you mind if I? Oh, it's just better for me. Sorry, I was struggling with the mic. Hi, thank you for having us here. The food was really great. I didn't go back 4 seconds, but it was really good. It was nice to have some like flavored chicken at an event, so that was really good. Thank you so much for having Dixon Hall here as a silver sponsor. We do have a booth outside, like she mentioned. We are helping with resumes and cover letters, so if anybody needs any help, definitely walk down to our booth and we're going to be here all day. So first I wanted to start by doing a little bit of a land acknowledgement. We would like to acknowledge that the land that Dixon Hall operates on is situated upon traditional territories of Huron-Wendat, Anishinaabe Nation, the Haudenosaunee Confederacy, and now the Mississaugas of the New Credit First Nation. Today, the meeting place of Toronto is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work in the community on this territory. So a little bit of a background of who we are as Dixon Hall. Dixon Hall started as a soup kitchen back in 1929, and eventually it progressed onto different departments, and now it's a multi-service organization. I'm here from the Dixon Hall Employment and Settlement Services. And just kind of to tie up everything that we've already heard from these beautiful presentations that happened in the morning, how is employment related to social and health? Like, how does those things tie in together? Well, employment is a key social determinant of health. As Dr. Curia already mentioned that there was the healthy immigrant effect. There is a healthy immigrant effect that happens. So one of those things that happens is that a lot of newcomers come into Canada, for example. They come in very healthy, and Dr. Curia beautifully explained how that happened, and their health often deteriorates. And one of the leading causes for that is definitely employment, because once you have sustainable employment, with employment you can get health benefits, health insurance, you have affordability for housing, and you have affordability to go to like specialized appointments. But without that economic stability, you're not able to get those resources. So to make things more accessible, we want to help newcomers and those having those access to like barriers to employment. We want to help them and motivate them. We work with them one-on-one. We have employment counselors that work with the individual one-on-one to give them help with figuring out a career plan, how to transition the role that you maybe had back home, and how can you take your transferable skills and how can you use that for skills that you can get a job in Canada. We help you figure out what are the bridging programs that you can be taking in order to get certified here. So that's a little bit snippet of what we do under employment services. Again, we have people working with individuals one-on-one. Our participation satisfaction is 90%. So as we all know, like I'm sure we've all somehow, or if not, our parents have immigrated to Canada, and the job market is not the same as it used to be. Before, we would see different trends. We would see people that are coming to us, they're struggling with jobs and they don't have a lot of experience. However, now we see a lot of people struggling to find employment. They have a lot of experience, but the market is so saturated that it's becoming really, really hard to find that employment. So, and that could be very challenging, especially if you're a newcomer. You're already struggling with so many different layers and layers of barriers and problems, and navigating that on your own can be very, very difficult. So our employment advisors, job developers, our entire team is there to kind of hold your hand throughout it. It could be either we can go speak to employers directly for you, or maybe you don't need that. You just need that editing of your resume. You need to figure out how to make a cover letter better. A lot of the places, like I know from my country back home, they don't have a resume. They have a CV or the way a resume works back in my country is very different than how it is here. So maybe a professional that's really well trained comes in with a CV from back home and they think they're doing a great job, but they're not even being considered for the job because of the format of the resume. So it's such a minor thing, but it does make a big difference. So our team is there to help with that. We also work with employers one-on-one. So employers might be looking for something specific, and we have so many clients that we can match employers with the right clients. We have volunteer mentorship programs where we have mentors that they had the same situation as a lot of our clients, but they're able to work with our clients one-on-one and on a voluntary basis to empower them, to get them past that fear and the whole question of what's going to happen to me next. So we're there, our volunteer is there for that mentorship and guidelines. We also have settlement services. So I manage 2 different departments, employment and settlement. So with the settlement services, we help newcomers, so integrate into Canada. So anywhere between filling out forms to accessing healthcare, we can help you refer to the right person. We can help you fill out those forms. We have settlements workers that speak different languages, Bengali, Hindi, Urdu, Saraki, Persian, so different languages. And if we don't, we also have volunteers that can help translate. So these are just a snippet of the things that we do in Dixon Hall. There's obviously our housing department is huge, and we have shelters as well. And our children and youth department, we have services for families that are of low income that can join music schools for a very subsidized rate. So when I say multi-service, I really do mean we're doing a lot. And because we're housed close by, and our departments, we can do internal sharing. So you come to our door for employment, we can refer you to other things. So it's somewhere you can come in, and we are there with you the whole time to help you with a variety of things. So if you're interested, definitely visit our booth and we can talk more specifics. And honestly, I'm really happy to be here. As someone with a healthcare background, I literally did my undergrad, my postgrad, all in healthcare, but I ended up in social work because it's so integrated, like mentioned before by Dr. Kiria and everybody else that just talked before me. So it is very important that we all work together and stay integrated, because social aspect and the health aspect is so combined. And in order to have a better mental health, to have better just social connections, it's so important that you're connected to the right organization. So definitely reach out to me if you have any questions. Thank you.
We appreciate you, Dixon Hall, especially when it comes to employment for newcomers, as well as settlement. Those are basic things that are extremely important. We definitely are going to have a question session a little bit later, unless there's an immediate burning emergency question. Is it there? I saw a hand up. But it's very important. Definitely. Can you keep it for a while? I definitely will choose you first when that time comes. Thank you very much. We want to thank you for knowing exactly where to put your funds. These are some of the places where you need to put your funds, because you add a lot of value to communities. And all the people that may come in as immigrants and as asylum seekers, they add a lot of value later on when they settle in. They add lots of value in Canada. They may seemingly come in as they need Canada, but at the end of the day, now Canada needs them in return. So that makes a lot of sense, doesn't it? Okay, we are expecting the emerging role of social work in primary health care. The Canadian perspective from Abel. Is Abel here? Oh, he is still for lunch. Yeah, that lunch was really good. So some of us are stuck in there still having lunch. Yeah, no harm. We can have him later. At this point in time, we are going to have 10 to 15 minutes, another presentation. Integrated healthcare in the African perspective. How many of us here are Africans? African origin. You were born there, you grew up there, you groomed there, you migrated there. I think all of us, there was a time when you go for your DNA, and I saw some white friends of mine telling me they have 3% of Africanism in them. And I also have like 15% of whiteism in me. So those things happen as long as you're a human being. It just, you will never know when when it will actually connect. We have Mrs. Salome Namvule, the founder of Pitmoff. Mama Pitmoff, where are you? Mama Pitmoff, stand up for recognition. Come on. Mama Pitmoff, thank you. Stand up for recognition. Thank you very much for being here. We really love you and the work that you do for the teenagers especially. Much of the social and health work is usually within teenagers, so we want to thank you. Mr. Tony Muzira and Mviri Ali, Center for Black Development Options Canada. Where are you? Right there. Thank you so much. And by the way, when you look here, all these are partners. This is not just for decoration. You see, what caught my eye is there are so many conferences that go around and so many bivrus, we call it bivrus sometimes. And this particular poster caught my eye, and I had to reach to the vision bearer and I told him that, you know what? I need you, you need me, we need each other, we are stuck together, and I'm going to be on this team. Because of this, there's some seriousness you see in something organized, and you're like, how can I miss out on this?
So we want to thank Access Employment. We want to thank Global Events Canada. We want to thank Media Inc. We want to thank Great Lakes Speaks, Dixon Hall already, of course, the government of Canada, Skin Novet, Hope for Hearing, Imagy Green. There are so many lots of here. Make sure that you get a business card from each of these people here. Are we together? Because you're not here just to listen, but also to take away something to be able to follow after. This is what we call following after, yeah? That resume needs to be taken, that job needs to be got. Yes, lots of opportunities. Canada is a land of opportunities, so we don't only want to stand on the land, but we also want to grab the opportunities. Hallelujah. So Dr. Ricardo, are you here, my dear? Yes, at this point in time, Dr. Ricardo John Munyengera is coming in. Of course, we already have something quite lengthy about him. Yeah, Africans are very good at describing what we are and what we do. Yeah, that's the energy. That's the energy, the African energy. You get me, yeah? Sorry about that. So we shall be able to read. Even back home, you can be able to read this particular profile. Let's go straight away into the presentation. Thank you very much.
Sure.
Mr. Ricardo John.
It's okay? Hello. Okay. I've just, when I was sitting there, I was trying to learn everything. This conference, I think, is getting me into the understanding more about we as Africans, but at the same time, how we take on health in the different perspectives. Not only where you come from, either from Uganda, or even from the rest of the global south. Oh, okay. I'm looking at that topic which is concerning integrated healthcare in the African perspective. Just as like our MC has talked about the aspect that most of us here has that element of African or being African, or at least maybe 30% or 1% African. I was trying to understand this integrated care because of what I went through myself. Just a short story. I had an accident in 2022, and right now I have an implant in my spinal cord because it was a burst fracture of thoracic bone and lumbar bone 1. So this is how I got to understand more about integrated healthcare in Africa. So I think without discussing a lot, I'm just going to look at some of the key concepts. What is happening in Africa? And at the same time, how do we take integrated healthcare in that narrative, as well as looking at the recommendations and the rest other issues in the conclusion. I'm continuing with this research and writing a paper in relation to this systematic review of what is happening there in integrated healthcare. So in some of the key concepts I encountered was the aspect of integration, healthcare, and integrated healthcare in itself. It has been defined by many scholars, but I want to talk about what Chelsea in the African context defined integrated healthcare. They looked at it as an approach characterized by a high degree of collaboration and communication amongst health professionals. So here, this is something which they looked at in the context of looking at medical professionals as well as clinical social workers and those who provide the services as the professionals. So in most of the African countries, it varies and the perception gets the narrative different from, for example, West Africa and also either East Africa or the rest of Africa, there is that narrative whereby you understand something in relation to how you perceive it. So that is how they looked at it. And then they gave a very good analysis of why it is so much important for Africans to take on that. So looking at the introduction of integrated healthcare, I found out some of the features as to which this has, but at the same time also the differing approaches. One of the issues which came up in the systemic review I did on the different papers was the aspect of the knowledge gap, whereby what is being discussed within West Africa is is very far from that in Eastern Africa, so it's the same in Southern Africa. So there's also the cultural context, which has also come in at a different perspective and bringing in many different issues. For example, when you look at social work and social care, especially within Eastern Africa in relation to Southern Africa, there's that element of Ubuntu, whereby you keep into interaction with the rest others in relation that I support you, you support me, and you are your brother's keeper in the context of even giving health. So that was one of the notions. And then, of course, others look at it in the context of being rehabilitative. This was found out, especially within South Africa, Malawi, and even Kenya, that it is something which is given and much more important. And then also the development of cells, or even besides the hospitals, there were also the development of integration centers, whereby people go and discuss about the different chronic diseases or the non-communicable diseases, and how social workers need to intervene. And then, of course, when you look at it in the context of also education, they were also looking at it in the context of how they must separate social work as a profession to social work and social administration. In most African countries, or especially Uganda, if I can give that example, social work was amalgamated to the social administration. But currently, the universities have also come up with the aspect of differentiating the two, that social work is independent of social administration, and now it's now a professional course. So when you look at it in that context, it has also brought about professionals who are working on integrated healthcare and supporting the clients or maybe the patients. When you look at the different models, there are many models which have been introduced in Africa, or even emanated out of the cultural context in the different countries. Some of them are like, for example, the inclusive or parallel model, and then the decentralized model, integrated, chronic, or either community-based. And these are some of them, even though many of them are differing. For example, when you look at the integrated community-based model, this is mainly in East Africa and Southern Africa. When you look at the inclusive model of healthcare and then integrated chronic, that one is much more into West Africa and Central, as well as the interdisciplinary and holistic model is something which is very unique to either Kenya, Uganda, and Malawi. So that is how they are looking at it. These different models are trying to make sure that integrated healthcare is something which is needed in the African context. So if I can give also in West Africa, for the consultative model is one other model which is being employed, especially the use of modern medicine and the traditional medicine into supporting patients, especially on the aspect of mental. And then there is also an interesting research which is going on in between Nigeria and Uganda in relation to how this consultative model is employed. So I wanted to look also at the components, the differing components in the integrated healthcare. These components are quite many, but to capture a few is like the chronic conditions, and then the patient involvement, and then the coordination and organization of care. So this has been exemplary, especially in addressing the issues to do with the chronic diseases as well as the non-communicable diseases. This one is one example where you can look at the aspect of how HIV/AIDS was handled previously in the 1990s and even to present day. That the chronic model was adopted and that it was successful in many countries, especially Uganda and Kenya, Malawi, and then Zambia later on. Then it was followed by also South Africa, whereby it was modified into the integrated approaches to care. So that some other issues were brought in, for example, membership of the different different patients, and even patients having access to the social workers, but at the same time as their medical professionals, and facilitating that understanding of the disease and how to handle it. That was something which was brought in that context, but at the same time has helped to alleviate some of the non-communicable diseases, but also the fight against HIV/AIDS. So when you look at the different cases, they showcase a different analysis, looking at the community-based model in relation to HIV/AIDS and non-communicable diseases, and where screening happens, but at the same time, what needs to be next, which is either the case model number 2 or number 3, and then finally a case model number 5, which cuts across each and everything. So when you look at these features, you can generalize them by looking at the different countries, as I made the review. For example, all of them are patient-centered, and then the accessibility is what is much more crucial, especially for both patients and the healthcare providers. And then the aspect of effective use of resources. Of course, the meager resources which are there, because the funding of health in Africa is something which is still wanting. And then, of course, the comprehensive, and finally, the holistic approach. So some of these are prominent in one country, and it varies to another. And then these approaches can be categorized. Some of the few categories I just brought out was the extending of primary care, clinical pathways, a community-based approach, then collaborative, the palliative, and then diagnostic, as well as the final one, which helped me out most of the time, which I call the integrated holistic approach, whereby patients with this holistic approach option is centered mainly with the health needs of the people, or maybe the patients, and then the communities, thereby enhancing community self-reliance. In this context, I mean, besides the surgeries I was going through, the social workers, the clinical social workers were there on time, but at the same time also discussing with me how I can go through the whole process. Because I was reduced, I was just in the wheelchair, unable to move, but there was need for that, the different sessions which were coming from the clinical social workers, but at also the same time, undergoing therapy, both physical and then even the psychiatric one. So when I look at it in general, I realize that integrated healthcare is much more something very useful and important in Africa, in case if handled very right. Looking at this, I cannot go without looking at the aspect of the challenges in the integrated healthcare. These are quite many, but I just tried to point out a few. For example, limited resources and infrastructure. This is something which is like in most of the African countries, in exception of, I think, South Africa. But the rest of the other African countries, they lag behind in terms of funding healthcare. Therefore, integrated healthcare in Africa is also a challenge. Then, of course, the cultural and the linguistic barriers. This is an obvious case, and in most cases, this has happened, especially in the central part of the continent and also East Africa. And in political instability, this is central, and the rest in the many countries. And then, of course, shortage of skilled healthcare professionals. Now, this one has two contexts. The skilled manpower, or maybe the healthcare professionals, most of them have left the continent. After training, they leave the continent. So they bring in, yes, there is training, but at the same time, there is that very big gap. So people tend to go for greener pastures, and this is a challenge to the different ministries of health in Africa. And then the high burden of the infectious diseases, or that is in case from it goes case by case from one country to another. So I looked at even the example of Uganda in the context of the poor medicine supply for non-communicable diseases has probably been the major setback to the effective control of the non-communicable diseases. I looked at this in the context of the analysis which was done by Moyo when they were trying to understand what challenges health workers facing in Africa, particularly East Africa. So there is, after looking at the challenges, there are also some opportunities which are being harnessed out of healthcare. We are looking, that's looking at its focus on in terms of prevention at early intervention, then integration of traditional and complementary medicine practices. This has been, much of the research has been done in Nigeria, Ghana, Uganda, and then Tanzania. So when you look at the potential for collaborative and interdisciplinary approaches, as usual, the medical professionals are hesitant in some regions of Africa to associate their research or modern medicine to that of the traditional medicine. This has been observed almost in every country. Yes, they say that, if I can, how can I term this? Issues of mental health, for example, how they are handled in between the modern medicine versus traditional medicine, it has a very big problem to convince people, to convince especially the health professionals that Mama Fina or maybe the medicine men can do something. So that is one very big, that's one very big difference in terms of integrated healthcare is implementing. But of course, there is also growing recognition of the importance of integrated healthcare. Many countries are taking it on, and then also there has been kind of like investment into integrated healthcare. I can give the example of Uganda. What is going on right at the moment is, for example, to the HIV/AIDS patients or those who have tested positive to HIV, where they are getting their medicine. So they have decentralized the system in that those who have been on that on the ARVs for some time, either 6 months and above, can pick their medicine through the different clinics within the area where they live. This has not been the case previously. So because of how it has been handled, when you look at how everyone has looked at it in terms of the policy, but at the same time of how the funders of this project are doing. They have helped at least the patients to get their medicine on time, which has been a problem previously. So, of course, some of the suggested solutions were many, but we can just look, just a snap through of a few. So, for example, develop and use African-centered health information systems. Information has been a very big challenge in most of the African countries. So, in case if that is solved, then it will create a very big impact. And then, of course, promoting community-based and patient-centered care. Just like I mentioned that having gone through the same system, the patient-centered care really helps, and this is what integrated healthcare talks about. Then, of course, not forgetting the interdisciplinary problem solving, right from the not only health professionals, but social workers, as well as community leaders, and then, of course, not forgetting the policy itself. Then, as we continue with the recommendations, there's, of course, decentralization and the devolution of health services, which I have mentioned. For example, if I can mention many countries in Africa, Malawi, Kenya, and of course, obviously, Uganda. I don't know why I'm repeating Uganda, but there is those people we call village health or VHTs, trainees. These have been much more helpful, especially in the rural community, in the rural part of Uganda, or even in Kenya. So, in terms of not only registering patients, but also advising them, working hand in hand with community social workers, those who have been now trained through the different universities. Some of the leading universities in Uganda, especially the private one, which started this, was the University of Mukono. Is it UCU Mukono? Uganda Christian University, sorry, Mukono. And then, of course, Chambogo University. They brought out two aspects. So, for example, the community social workers who are attached to the different, not only to the hospitals, but attached to the communities, so that at least they can identify, register, and advise patients to at least follow up on their medicine, and also give them the chance to get healthy. On the other aspect, of course, there is digitization of health. Right at the moment, as the digital space is increasing, it is not only affecting these other spheres of life, but also even into health, whereby a lot of not only advancement, but also the aspect of talking about how social workers, how health professionals are handling different discussions, forums, and then, of course, conferences like this one, so that at least knowledge is distributed, and at the same time, someone can learn a thing or two. And then, of course, community engagement and participation. So community engagement in the context that right now, it is not exactly that in education, if I can use that example, that clinical social workers are not only attached to the hospitals, but also even to the community. So the holistic approach and the learning processes which they go through have helped to change the system, and at the same time, the perspective of healthcare in general in Africa. I think my time is up. Thank you so much.
When we start talking about knowledge and people's well-being, it will take so many days and so many hours. We can never exhaust. And that's why annually this conference runs. So every time it's going to run, be the first one to sponsor, to register, to volunteer, or to register to be an attendee. Let's give him a wonderful hand clap. Thank you so much.
There's so much to learn, and there's so much new knowledge that comes to best that we need to always revisit and refer to. At this point in time, we are going to have our questions and answer session. That is one of the sessions that I love so much, because from you, we have very many dignitaries that have something to say or something to ask about something that has probably been left out. So at this point in time, for those who presented earlier, please just come and sit on these softer, more comfortable chairs, please. And then we shall go through a quick question and answer. And while they come, I just was here and I thought about the word mentor. Many times in healthcare, we are so quick to see the blood, someone is bleeding, someone has a big wound, or someone got an accident and needs physical help, or physical medical help. And many times we forget the mentor. Mentor is like a cancer that eats us slowly but surely. You get that disappointment from a loved one, disappointment at work, disappointment with your children. It can be just about anything with the finances, and it worries you all the time. You even lose sleep and you don't even want to eat. So slowly but surely, if you do not take care of it with the therapy here and there, it eats you up, and before you know it, you can't be as creative and as well as you should be. And the moment the mental health has issues, definitely the entire health of a being becomes a problem. So the word mentor, M, would be medical therapy. Quite quickly, run for it if you feel that that's what you need. Or mental therapy, you can have your own positive thinking. Divert yourself from the negative thinking of a situation eating you up and start thinking hopefully and positively about it. And sometimes, many times, we get the answers quite handy. E stands for emotional therapy, from loved ones, from family, from relatives. Okay? And then an N is nutritional therapy. Are you taking too much sugar and it increases your stress levels? Are you taking too much oily food? So try to go vegetarian, try to go fruity, so that you get that nutritional therapy to take care of your mental. And then T is traditional beliefs. We have those stories that our grandmothers used to tell us that actually instigate a lot of positive thoughts that make us feel better, even if the problem still stands. So traditional therapy is very key, the beliefs that we have from our traditions and culture especially. A stands for art therapy, music, dance, and drama. We just saw her here dance and sing, and there's a way you put that smile on and feel much better. And the last but not least is L, standing for love therapy. If you can get someone to love you silly, please do, so that you feel better mentally. Yeah, beginning with God, okay? You have the love of God, but also love from a loved one, a real intimate loved one. These things sometimes work. Okay, I will go at the front and you give us the questions. I've been looking forward to standing up here, and I'm happy that, good evening, viewers. All right, I kindly request Clive to move with the microphone to, okay, she came first, and then we shall have Lydia. Lydia is one of the vision bearers of this amazing conference. Yes, my dear Black Beauty, what do you have to say?
Good afternoon, everybody. My name is Annabelle. I'm a Ugandan. That is good. I have a question. It's kind of burning me, and I would like to address it to, I want to address you as Miss Alam. I think I'm right. Back home, I was a technician, IT technician. So I came with a lot of expectation to come here and maybe do something in IT. But when I came here, things were so different because the rate of technology and advancement here doesn't no longer match with my mental health. So I was like, okay, what should I do or where should I be? So I decided to go social services. So I recruited myself to do mental health and addiction program. And the challenge is wherever you go. Hello?
Yeah, we can hear you.
Hello?
Yeah, we can hear you.
Yes, she's with you.
Oh, yeah. My challenge is now you've spent 2 years doing a diploma in mental health and addictions. Here you come with your resume and a cover letter. You post it everywhere, they're advertising, and if you are successful, they call you for an interview. The next thing is they want the Canadian experience. So I want you to help me understand which company is going to recruit me without the Canadian experience. Because, at Dixon Hall, do you have training and development opportunities that we new job seekers can have so that we can gain relevant experience, relevant Canadian experience? Because it really it disappoints somehow. And when you are ready to work and they ask you for 3 or 2 years experience and you are from the college, but they still need the experience. So where am I going to gain the experience? Which company is going to recruit me without experience? That's
They-
my problem.
They are
Okay.
clapping. And on top of that,
Thank you.
when expatriates come from what we call the extremely development countries and they come, maybe they go to Africa or to Europe, they never ask them for work experience in that very country where they have gone. I'm just saying, it's not me, it's them that are saying. So we need to understand that. Thank you. But at least we have Dixon Hall here and the rest of the others to give us those answers.
Yeah, and that's such a fair point, and that's something that we recognize as a barrier for a lot of people. And honestly, it's not like right now the government has removed that Canadian experience aspect from a lot of jobs, unless it's like regulated professions. Most of them, they're not supposed to ask for Canadian experience, at least in the government that has been implemented. But it's about the mindset of the employers that need to change. So even though lawfully they're probably not supposed to do that anymore, they're so used to that culture of that being the standard that they're not changing those cultural practices. So we always encourage because obviously you can't go back to every employer and do an EDI training or something like that to kind of teach them that you should do that. So as Dixon Hall, what we do is we stand as an advocate for our clients. So we work with employers one-on-one, speak to the employers, and we kind of tell them that, look, this person has all this experience, and they would be a really good fit. Some places you do need Canadian experience in terms of education, but other things you may not need a Canadian experience. You just need, let's say, volunteer experience. So, for example, I have an example from a client that came from Uganda. She was a teacher back home. She worked in social services. And then when she came here, she lives in a shelter with her 2 children, and she's looking for employment. She was on Ontario Works, which is like government support. And obviously it wasn't enough to, help her with her living. But then she started volunteering. So she volunteered for 3 months at an organization, which was a health organization. After volunteering, she was able to make connections. Like first she volunteered at one program and then she volunteered at another program. And that helped that employer kind of, take away that bias, exactly, the bias and that mental, like the little thing that you think that, oh, they're from another country, they probably can't do the job. But they were seeing that as a volunteer, she was bringing a lot to the table. And then the employer, because we provide incentives to employers as well to hire our clients. So then we ended up providing an incentive to the employer where they had a position available, and we said, why don't you take this person on for 3 months and see if that, like, just do like an on the job training for the person. And then if they fit right with the role, then they can become a full-time worker for you, but that onus is on you to employ them. But so as a service provider, we are here to provide that, advocacy, the incentive, things like that, to kind of be that middle person for our clients. So I would suggest volunteering is a big thing. I know it's hard and it's just a slow process, but even me, I graduated with a degree in Canada. I went to school from grade 9 to everything. And then after I did a master's and everything. And when I graduated, I applied to 60 jobs. I heard back from 2. I have Canadian experience. I worked all of grade 10 all around. Like after undergrad, I worked for 2 years as well. It's hard. So even as Canadians, it's hard. So I can't even imagine coming to a new country, how difficult it is. But with me, what got me a job was my volunteer experience. I volunteered at an organization. Eventually, I became a director of an organization and on a volunteer basis. And then from that is when that opportunity and the gate opened up for me. So volunteering, networking with the right people, you're here already. You're already doing step 1. So today, speak to the person next to you. Speak to someone that is in the field that you want to work. Ask them specifically, like, that's a role I'm interested in. What do you need for me to get that role? We have people that are really interested in personal support workers. We're here today as an agency, but also as a way to kind of find out from those employers that, like, what do you need for our clients to become a personal support worker? Do they need to go to school? Do they need this? So ask those questions and network. And yeah, and hopefully, like, it's a long process, but you're already in the good direction and like you're taking the steps that needs to happen to get a job. So don't let it discourage you.
That's wonderful. Thank you so much. And we all know that some people get jobs through Indeed. They're back in their countries, and through Indeed and LinkedIn, they actually get jobs. And when they come here, they are trained before they get into those jobs. So in the process, you realize that they appreciate you before you even come to Canada. So I think we are hopeful. Thank you. You've really addressed it so well. Yeah, let's not fear to volunteer, but this time around, be intentional when you're volunteering. Go to that particular area where your discipline falls. Don't scatter your professionalism or your talents here and there. You know, if you're a nutritionist, then go to a food bank and volunteer there, or a restaurant, or, I mean, it can be anything. If you're a health worker, go to those areas where your services are required. Because when they realize that you're very good and you've displayed expertism, they will create a desk for you, even if the office is not yet there. They will realize that they need you more than they thought. So the most important thing is when you're volunteering, what are you displaying? Are you being that person that creates a gap in an organization that they would like to retain you? You have to be your best as you volunteer, because you're placing yourself and giving yourself an opportunity for people to appreciate you. We want to thank you so much. Do we have any more questions? Clive? Oh, yeah. Oh, yes. Yeah. 3 more, 2 more. You have something to add?
I just wanted to add one thing or two. That is in the context of those ones who are in universities or maybe in colleges. Okay. Is it okay? All right. So those in universities, especially applying from there are 2 things you must do. According to the advice I got from my own supervisor at McGill and even the rest of the others, is that when you are trying to do your research, do it in the context of Canada. Not maybe, for example, you are doing your research, but you need to go back to Uganda. So your experience in research is going to be in Uganda. So when they are recruiting here someone in relation to research in the same topic, they will first consider someone who did theirs here. I'm one of the example whereby I was doing research on the refugees in Uganda, but I realized that I need also to do some work here by doing research on refugees in Montreal. So that was one area of covering experience or even getting the Canadian kind of like job opportunities. The number 2, which my supervisor also encouraged, was the aspect of you in terms of placements, especially those ones who are pursuing their masters. Instead of going for the traditional thesis program, you go for the one which calls for a placement within Canada, so that the university will help you to get a placement in a different, in an organization, or maybe even be it the government, so that is used as an experience for you to working within Canada. That's the only thing I wanted to add. Thank you.
Okay. Good afternoon, my people. My name is Lydia Namgain. I have a question. I think it goes to Dr. Ricardo John. So my question is, how are current mental health trends influencing healthcare and social work? How are current mental health trends influencing healthcare and social work?
Okay, thank you very much. I think he's got it. Can we have another question? We have another one there, and then we shall respond. Thank you.
Yes, thank you so much. My name is Tony Muzira, and I work with the Center for Black Development Options Canada. We also have an upcoming conference next month on the July 4th and 5th, the International Conference on Black Immigration and Refugees. Ours is just to voice policy issues that affect us in this country.
Can you
as we
tell us,
integrate.
sorry for interruption, tell us that, please stand up. I
Yeah,
beg
so
you. Thank you.
mine is not a
Can
question.
you stand up and tell us that organization? There's some information we've missed. Yeah, you know, when you're marketing yourself or when you're marketing something, we really need to get it clearly. Yeah, because we need, from here, we are coming there. Yeah, sure.
Thank you, but anyway. Yes, so I work with the Center for Black Development Options Canada, and we're organizing the first international conference on Black immigration and refugees. It's basically policy matters that we are talking about here today. Mine is not a question, but I'm just kind of like providing information. My sister was talking about Canadian experience. Apparently, we are actually working with the Ministry of Labour, Immigration and Skills Development through the Ontario government, the promotion unit, so that they're trying to create information to employers, but also to attract job seekers by providing most of the resources. And one of the things that is being discussed apparently is international, is Canadian experience, which may be scrapped off or create other synergies of how people can integrate. So this is something that is upon discussion, and I would say Dixon Hall may not be in the position to answer that, but it's a policy matter, and these are things that we are going to discuss in the conference to provide policy recommendations, because it has been long overdue. But it's not a matter of just talking about, we have to move from policy to practice. So we create policies and then we practice them to make sure that they benefit everybody. Thank you so much.
Thank you very much. Do we? Okay, I think we are done, just about. Okay, thank you very much. Do you have a question, Mama? Are you sure there was? Oh, yes, yes. Directed to you. Lydia's question.
Okay.
Oh, yes. Sorry about that. Thank
it's
you,
okay.
Ma.
All right. So the question was, if I got it right, concerning how are the trends influencing social work and mental health? The current trends as in the context of Africa or maybe here, both. Okay. Let me start from home. Or what is happening in Africa, especially in Uganda. With the new way of how, for example, social work is being taught, or how the course in education has changed, it's now bringing the aspect of many clinical social workers, or those ones who are really called social workers. Because previously, just as I mentioned earlier, we had a course called SWASA, Social Work and Social Administration. Now those two have been separated. Right now, Makerere University, in the past 2 years, made social work an independent professional course. So the products who have come out of that course, all of them, and they are not yet out, but I think the first batch is going to be out this year, is that they are well trained, and as a professional course, many of them are being attached either to mainly hospitals and then even to the to community. They adopted this from Chambogo University, because Chambogo University was the one which first started on professionalizing the course, but at the same time also putting it in context that at least it is beneficial to the community. The other aspect, in looking at it in the context of education, that's how it has been handled. That the new trajectories indicate that it is progressive, and there is all the chance that the products of maybe the trained people from Uganda are fully trained in social work. So that is one something like an advantage. And I have seen some of the social workers even getting their education here just straight away from their undergraduate and then a master's. There's a MasterCard Foundation and the rest others who have come even not only to McGill University, but I think also at York as well. So there is that opening in terms of that. Now, on the aspect of mental health, for the professionalism, it is okay, but it has not been so much receptive to the patients. I'm talking from the experience I had, that, okay, you may have a conversation with the social worker or the clinical one, ABCD, but again, your doctor may overlook her or his recommendations. So there's a very big, again, that knowledge gap which I mentioned earlier on in the context of mental health, especially how it is being handled in the African context. Now, when it comes to here there's a lot of issues which have arisen out of mental health. For example, the earlier speakers mentioned the aspect of where a man goes to the hospital, but is brought by let me say the husband is brought by the wife in that context. It is also it is also something which is again a challenge, in that the perception of mental health is vis-a-vis the whiteness of someone or the blackness of their color. So that is and it has brought in very many questions, and then of course not forgetting the aspects of the LGBTQ and the other aspects. I had a presentation, especially after the act in Uganda on that, and I interviewed some of the refugees because they are much more fascinated about understanding the aspects of refugees. So refugees who are in the LGBTQ vis-a-vis the Anti-Homosexuality Act, mental health came out as something which they were challenged with, and it was a very big problem. So to me, that's how I can simply try to tackle that question. But it's an evolving one, and it's big in the context of Canada vis-a-vis the African context. I'm also just trying to learn each and everything. So maybe you can something. Okay. Yeah.
Thank you very much. We need to close this session. Are you adding to this, or you're asking another question? I will give you half a second to do that. Thank you.
Yes, and I will wrap this session. So my name is Eclair Winfred, and I'm a public health specialist, and I also have a social work background. Yes, so I wanted to give an observation in terms of comparison between the linkage and the referral system in Canada and back home. I think it's so strong here. If I went to a doctor and I needed another service, I'm going to be referred to another organization or supporting partner, and I'll actually get the service. But back home, we are really challenged. I'm going to be referred by a social worker, for instance, for legal services. I need to have other social health issues, like a livelihood issue, and the the social worker is going to play their job of referring me, counseling me, and then I'm not going to go to where I'm referred to because I don't have transport, for instance, or the other organizations don't have the financing to support my other needs. So I think that's a very big observation. Yes, so that's something we can learn from as social workers who have come from Africa to attend this conference. Yes, so we need to see how we can document best practices from non-profit organizations here, but also it's the government that provides some of the services and resources, which is different from home. Organizations are really struggling. We have good programs in terms of social support, but we cannot provide them. And then we are drained mentally and emotionally as social workers. I cannot see my client suffering, for instance. I'm talking to her about the needs, for instance, to adhere to treatment. And then she doesn't have food. So I'm going to tell you, oh, I'm going to refer to Alex. Alex, you need to take your medication on time so that you suppress your virus. Alex is going to listen to me, and when he goes back home, he's going to throw the tabs because Alex has no food, for instance, to swallow other medication with. So I think that is something that is pertinent for us to learn from. How do we finance the organizations and support social workers? Because we have a session on mental health and wellness. We are drained mentally. Thank you.
Thank you very much. We will not allow to be drained mentally or health-wise. That's the reason why the conference is right here. Come on, give the vision bearers a very big hand clap for this wonderful, very, very creative, extremely patent issues. And then let's clap for our panelists. They've done us so much good. Thank you very much. And let's clap for a lovely audience. You are amazing. You've made all of us very proud. In a special way, we thank the committee members. You're very amazing. Our sponsors, donors, you're amazing. DJ, thank you. Give him a hand clap. Thank you so much. Okay, at this point in time, I think I need to invite Mr. George.
Thank you very much. Sue is a very interesting person. I have been pulled off my seat to officiate the next part of the conference. And my name is George Wilobo, and some questions that were raised here also are, of course, very pertinent to policy development. And I must acknowledge that as organizers of this conference, we extended an invitation to some of the policymakers, including, among others, we invited the Ontario College of Nurses, we invited the Ontario College of Social Workers and Social Service Workers, we invited IRCC, we invited Public Health Ontario, we invited Public Health Canada, and they didn't send their representatives or they didn't honor the invitations. But otherwise, we have a desk that is right from the person that just spoke, Winifred. We have a rapporteuring of the event. We are covering this event, of course, live streaming it as well. And also, we are capturing the communique, which we are going to send to these institutions for informing policy. Thank you very much. Without further ado, we are going to end early. But before we end early, we have a very wonderful last session of this event, which is interactive wellness session. And this is being done by Charlene Gams, a registered therapist as well. And may I know if we have Felicia here? Oh, yes. So, Felicia, I think the registration never captured you. And, oh, yeah. Oh, this is Charlene. May I know if we have Felicia in the house? All right. If that is not, then may we have Charlene Gams to take us through the next session. Thank you very much.
Hello. So I feel like I've gotten a lot of buy-in already today because it's time to think about yourself and do some self-care. So I'm Charlene Gums. I am a registered social worker and psychotherapy therapist. And today I'm going to take you through some coping strategies, okay? Give me 1 second. So all of the strategies that I'm going to do today are trauma-informed, but I am going to do the typical trigger warning. Do what you need to do to stay safe, which means if I ask you to close your eyes and you want to keep your eyes open, that is fine, okay? So today we're going to work on our emotions. And sometimes our emotions shows up in ways So just gonna wait for the presentation to get up, but I wanted to remind you that being in touch with your body is very important because sometimes our emotion shows up in ways that we're not aware. How we treat our clients, how we treat our family, how we treat ourselves, okay? So today, I'm gonna have you really start to think about your emotions. So right now, I'm going to start with a meditation, okay? A guided meditation. So sit comfortably back in your chairs with your back straight and your eyes closed. Begin by focusing on your breath. And feeling the air going into your body and then leaving your body. So I want everybody to get comfortable. Close your eyes. Let's take a pause. Let's take a breath. And place your feet flat on the floor. Often we carry things that we bring home from our clients. So this guided meditation, hopefully, will allow you to notice how your work is affecting you. Now place your hand over your belly or over your heart and take 6 deep breaths. Noticing your stomach rising and falling with each breath. In and out. Take the first client that comes to your mind. Who is that client? What do you sense in your body? Just scan your body and notice what your body is doing. If you'd like, you can write it down. What do you notice? Are you getting bigger or smaller? Colder or warmer? Tense or relaxed? As you bring this person to your mind, now turn your breath inward. Does your breathing change? As you notice this person, how are you feeling in your body? What do you feel as you look at this person? What fantasies or pictures come to your mind as you look at this person? If this person was an animal, what animal would it be? What animal would you be interacting with their animal? What do you like about this person? What don't you like about this person? What do you need this person to do? How is this person like you? And how is this person different than you? What does this person remind you of? Who does this person remind you of? How are they different than you? And how are they like you? Take a few breaths. And then open your eyes. Reflect on the person that you picked. Were you surprised? What personal issues came up for you in that meditation? How can those issues and reflecting on those issues support you as a person, as a social worker, as a student, as a parent? Emotions are powerful. They come out in many different ways. That meditation was meant for you to focus on your emotions and potentially an interpersonal struggle that you're experiencing. And I know there's many social workers in the room, so most of you know what countertransference means. So we don't just bounce all of the things that our clients bring to us. We absorb it. So taking a moment to really connect with your body and figuring out what you're absorbing will lead to better self-care, okay? Whether it's through meditation or prayer. Okay, now we're gonna do therapy exercise, okay? This is an art therapy exercise. It's a technique that feel free to use with your clients if you really connect with it. There is no rules to this. This is your self-portrait. Who are you today? How are you feeling? Okay? On your tables, you should see paper and crayons. Get creative. Okay? We'll give you 10 minutes, okay? So again, there is no rules. This is about you.
just fine before I met you. I drink too much and that's an issue, but I'm okay. Hey, tell your friends it was nice to meet them, but I hope I never see them again. I know it breaks your heart. Moved to the city and I broke down.
Don't overthink it. Get in your childlike mind. Okay? We don't use this mind every day. So a lot of you are like, I need specific questions. Just be free flowing here. Hello, lovely people. Just like life, sometimes times are unexpected. So today we have to just wrap up a little bit early. But, you know, if coloring really connects with your inner child, then that is a great coping strategy. There are other great coping strategies. Earlier we saw dancing and singing. So you do what you enjoy in order to lower the stress levels is the point of this activity. So I hope everybody was able to put their emotions on paper. And yeah, my next activity was going to be around discussing our issues with each other and being able to debrief with each other. So I'm just going to encourage you instead, talk to each other. Give each other supports around coping strategies. Offer each other suggestions, okay? As a community, we can also support each other and help each other support our mental health, okay? So thank you very much, and I will pass it on to George.
Thank you very much. So we've got some emergency as well. If you've been watching on social media or the media itself, we've been hit by an announcement by the Ontario Science Centre with regards to, I think, closure of the property to the public. And because of that, it is actually affecting our programming as well. This was not expected. It was also expected by management of the property. However, in a discussion with the management, they have allowed us to continue with the conference today and tomorrow. And because, thank you. And because of the emergency situation that came up like that, we must be able to go now again and re-communicate and reassure most of the colleagues and folks that were prepared to come over and be with us tomorrow as well, but also making sure that there is continuity. And also with that same regard, we are very sorry, Charlene, you are not able to finish the fun part of your I drew mine here. And I was really ready to explain why I did this and that. However, with regards to what I've just announced or mentioned, allow me give an opportunity to young caregivers to provide a few minutes. Caitlin Holden to give a remark on her abstract, and then we can be able to close up, and then we close early, and then we can go on to the next, at least we prepare for tomorrow. Thank you very much. Caitlin.
Good afternoon, everyone. Thank you so much for allowing me the opportunity to come and speak at this conference. My name is Caitlin, and I am the intake coordinator and community engagement facilitator for the Young Caregivers Association. So I'm here to talk to you about identifying young caregivers, mobilization, and then I will also talk a little bit about our organization at the end of my presentation. I'll get through it as quick as I can. It's not very long, I promise. I don't have my credentials yet. I'm a fourth year BSW student at McMaster, so I'm not as qualified as everyone else in the room. But so I want to start off by talking about who are young caregivers. So young caregivers are youths, children, and young adults between the ages of 5 and 25 who provide care for a family member through either personal, emotional, or financial support. This can look anything like caring for a sibling, parent, or a grandparent with chronic illness, disability, mental health concerns, substance misuse, socioeconomic factors such as multiple sibling homes, providing the family translation with language barriers like medical appointments and things like that, or in single parent homes where there's that little bit of a lack of responsibility on the single parent. So there's several different types of caregiving, and we look at them in 3 separate categories. We have our practical, our physical, personal, and our emotional forms of caregiving. So primarily we see emotional caregiving responsibilities falling into the younger demographic, so the children ages 5 to 12, because it's difficult for younger children to provide physical care roles. So instead they take on emotional responsibilities such as being that emotional support person, worrying about their family members, having to deal with meltdowns from siblings, and also carrying a lot of worries, so they try their best to cheer up their family members. And then we see them moving into more of the practical and physical caregiving as they age into adulthood and take on more of that home care, medication administration, grooming needs, and filling in those extra holes. So in Canada, we estimate that there are approximately 1.25 million young caregivers across the country. However, this estimate does not include children under the age of 15, nor did this survey include the territories. So we do estimate there is a significantly larger number of caregivers. So let's talk about the impact of caregiving on these youths. So although caregivers play an important role in their families, they are often forced to grow up quickly, and many feel as though that they have missed out on their childhoods. This and added responsibilities in the home can lead to feelings of loneliness, sadness, anger, and frustration, and as well as these youth have deep feelings of isolation due to feeling different from friends and peers, which leads to suicide ideation and self-harm without intervention. As well, young caregivers provide a significant amount of care that equals to a part-time job, as well as effectively saving the government money on in-home care professionals as well as live-in care facilities with an annual savings of $25,000 to $50,000 per month per family on our healthcare system. We also see how age is a factor in these experiences, and younger caregivers experience higher levels of burden, psychological distress, and have fewer of their needs met. And we identify those experiences as caregiver burden. So caregiver burden is a multifaceted strain, but on those who are caring for family members and loved ones over time, and these consequences increase negatively over time without intervention. So self-perception of how their own self-image is altered in their experiences as a caregiver, they may not even view themselves as caregivers at all, and each experience on each individual is unique. Many rely on their caregiving roles as means of self-esteem and self-worth, and the multifaceted nature of caregiving burden has effects on these youth in different ways, such as their social development, mental health, physical and social developments, as well as these impacts change over time and differ depending on the life stages of those youth. Caregiver burden is not static and changes over time, and the young care who they care for, the age of the care, and longevity of care provided. So as many of you are healthcare professionals in the room and social work professionals or have some experience in the field, it's important that we learn how to support young caregivers and identify them in our practice. So what's most important is recognizing barriers to receiving support. So we don't consider children in the home as helping with care. We have feelings of guilt for asking for help or even cultural considerations. As well, many are not aware that they are caregivers and are just doing what they feel needs to be done. Parents who require care often do not have their parenting needs considered by the supports they are receiving, and their children are left out of our conversations. Some keep their situations a secret out of fear, stigma, or unwanted interventions, and it may be difficult to engage with families depending on those circumstances. The needs of the family may only be identified when there is a crisis, or we do not have the mandate to ask children in the home how they are doing. And many professionals lack the capacity to even engage with children and youth and do not know how to respond. It is these barriers that make identification of caregivers important if we are going to be able to support them. So why don't they get identified? Typically, the term caregiver or carer is associated with paid professionals in adult positions. With both of these terms also being highly westernized, it does not account for cultural impacts that includes form of caregiving provided by children and households. It is important to consider the terminology used, as not everyone associates or agrees with the terminologies, and this aids in not identifying our caregivers. Fear and stigma are also the major reason why caregivers are not identified. This may be due to the fact that families who are aware of their situations may be reluctant to identify due to stigma and reactions from professionals. In many cases, it is unidentified deliberately to conceal these caregiving roles. As well, with these families, there is a significant level of children who become apprehended or families are investigated when they are seeking these supports. And generally, it is not sought out until these children have turned 18 in fear of these apprehensions. As an example, in my time as an intake coordinator, we received an email from a 10-year-old little girl. She lived in London, so we service the Niagara region, so she's a little bit outside of our area of help. She contacted us seeking support for herself because of her brother who has mental health concerns as well as an intellectual disability. She ended up leaving us with her mother's phone number and email for contact. So I grew up in London and I'm very familiar with the agencies in the area. And so I reached out to try to find her the supports that we could not provide her. And almost all of the responses I received back told me to call CAS on the family. They told me to open an investigation. They told me to just pass it off to them as it is their jurisdiction. And this was agencies that were built to support children. This exact reaction is the reason why young caregivers are unidentified and unsupported. With all of these in mind, we as professionals and community members must understand who young caregivers are. We must understand the reasons why families do not come forward independently, and we must know our roles and responsibilities when identifying and supporting young caregivers. Knowing how to identify them and knowing the right questions to ask, and especially knowing how important it is to identify early, so we can ensure that they are as connected to services and supports who acknowledge their family roles. So when we put this into our practice, it is important to ask questions. So when we have a family in our care with a member who's been given a diagnosis, it's important to ask, are there children in the home, how they were impacted, and the types of things they do. We also need to look for less obvious signs, like is there stress in the home with children? Are children coming up frequently in conversations? And is there an absence of family activities and recreational outings? And as always, we should be empathetic. Opening up is hard for many families, and we must make it clear of our intentions and who we are there to support, and not just solely for the individual with the diagnosis. As well as being knowledgeable and having a good awareness of support and resources that exist in your area, so you can offer it to families and are willing to provide referrals. And speaking of resources, I could talk about myself a little quick. So we are the Young Caregivers Association. We were established in 2003. We began from the Alzheimer's Association and kind of budded out of there due to the need of young caregivers in the home of parents with dementia. So since then, we've worked hard to transform the lives of the invisible population of young caregivers and young adults. And we're the first and only organization in Canada dedicated to support these young caregivers, their families, and bringing awareness across the nation. We try to give them the tools and support that they need to positively impact their lives. And then the biggest part of our organization is the Powerhouse Project. So it is a recreational program that offers these kids and young adults the chance to take a break from their responsibilities. They learn skills, and we have life skills programs, and meet other kids who understand their situations intimately and are able to build a community of support around themselves. If you go to the next slide. Thank you. So these are, we administer surveys to our kids every quarter, and we're able to track and see the impact that we have on their lives. You can see this incredible impact that we have on these children in our program. And it is in our goals to ensure that every caregiver that we come across and everyone who comes into our care gets what they need, leaves us feeling better about their roles, know their worth, and are able to cope with their daily lives. As well, for professionals in the room, we have a referral map that you can see and access on our website. Next slide. Thank you. Which you're able to take a look at. We service as many locations as we can, and it is everything in our power to do to change the lives of these children. And then I have references, and so thank you for listening.
Thank you very much. If there is any question for Caitlin before she leaves the stage, this will be the best moment for her. If there is none, thank you very much, Caitlin, and we appreciate you being here today. So, as I mentioned earlier, the news of the structural closure and all these other things is making people panic a lot. And out there, this information is being consumed differently. It's being consumed very differently. And as the committee that has been planning this for months and months, and also the implication in terms of financing it and all these other things is really so much affecting us, both emotionally. Our mental health is not steady very well because we must convene again and really come up with a strategy for the next step. However, I want to appreciate everyone that has been able to show up here today. The audience, you've been such a very wonderful crowd. I want to appreciate the speakers that were able to honor the invitation to speak on this panel today and in this platform. But above all, I want to thank the organizers of this event. And allow me call the team that I should introduce you, the team that I've worked with. I have that entire table. Please come in the front here, and then Joseph, please, just real quick, as we wrap up, we are closing the seating for today. As we are here as a team, and we are here to be able to bring this idea to life. And it is today that we've confirmed and realized that it wasn't just an idea. It was something that influences and impact lives. And I want to appreciate the men and women. Oh, there is only one man. Okay, there are now two men. I want to appreciate the people that you see at the front here, and some of those that are busy outside and different aspects of what they're doing today. They have been very instrumental in putting together everything that you're able to see here today. Every ideas, and all our volunteers, if you can, please join us here. the volunteers. Okay, just wave to us. I know you are very... But our last activity of today is a group photo. Please allow us come to the front here, and then we do a group photograph, and then we can call it a day. Thank you very much. We can do it from the photo booth. We're going to do that from there. Yeah, from the photo booth, let's do a photo group. Ladies and gentlemen, thank you very much, and we appreciate your presence. We are here tomorrow again. Outside, the usher? Yeah, so we are taking the group photo from outside.